Check one, two.
Good morning, everyone. Welcome to the Insurance and Real Estate Committee's informational forum on impacts from the federal budget to state insurance plans. Today is October 1st, 2025. And we'll first start with opening remarks. I just want to thank everyone for their time. This is a very important moment in insurance. And we're really happy that everyone came together for this. While the federal government may be closed, Connecticut state government is open and ready to deal with any of these issues. And we look forward to making that happen and taking care of the constituents of Connecticut. Senator Cabrera.
Thank you, Representative. Good morning, everyone. Thank you all for taking the time out of your busy schedules to be here and talk to us today. I know you have all seen what happened last night in Washington. I know we are concerned about the expiration of the Obamacare subsidies that happened in the end of the year. We're hoping that fairer minds and more balanced minds deal with. But in the meantime, we'd like to hear from you to see what impact this is going to have on our citizens here in Connecticut. And that's what this is all about today, to give us some idea of what's happening, what you expect, and how we can meet the moment. Thank you.
Thank you. Any ranking members online would like to say anything? All right, we'll jump right into it then. First, we have Claudio Gualtieri and Zani Nekenmowski from the Office of Policy and Management. Zani, did I say that correct? Thank you. Okay, I'll get it.
Thank you, Chairperson Wood, Chairperson Cabrera, members of the Insurance Committee. Appreciate you guys convening us today. Zani and I are here to present on behalf of the Secretary to give a holistic overview of some of the changes in H.R. 1. In particular, we're focusing on the impacts for healthcare coverage and the health insurance exchange. So before we begin, I want to acknowledge that conversations like this are so important, as Senator Cabrera said, so that we can meet the moment here in Connecticut, but also help the public separate out some of the anxiety and the myths from the facts and the timing of these changes, which is so important. We all know that the One Big Beautiful Bill Act is going to change the trajectory of our health and human services social safety net for 5-6 years to come. And it's important that we sort of stage out what is in the near term, that we have some guidance around that we can build solutions for, and what are some of the longer term things that still are awaiting federal guidance. So our presentation today will focus on a couple topics. We'll start by giving you a quick landscape overview of the federal state of play. We'll then do a review of a timeline for major health and human services changes in the next few years, broken out by state fiscal year. We think that's important because that's how we budget, and that's how we may have to figure out solutions and funding. Second, we will talk through Medicaid changes, and I know DSS is here to provide a little bit more granular detail and help answer questions. We'll talk then about the exchange. There's some direct impact on the health insurance exchange. In Connecticut, that's Access Health CT. We'll then wrap up by talking about potential policy considerations, both in the short term and in the long term, and the next steps that we at the OPM team, in conjunction with our state agencies, are planning. So with that, I'll ask Alex to turn to the next slide and have Zani do a landscape analysis for the federal government.
So generally, as was mentioned, there are a lot of moving pieces. Major changes have happened to H.R. 1 and changes to the Medicaid in the future, and still require federal guidance from the federal government. and including the federal government shutdown. For example, the main Democratic ask are the expiring ACA subsidies, which have bipartisan support. And third, the ministry has taken administrative action to change the way we administer programs and funding. So as you can see, the first thing, there are numerous changes to Medicaid, SNAP, student loans, Inflation Reduction Act programs, and tax policies. And these are taking place in the future and kind of parsed out through the next couple of years. And then the thing that we're waiting on, which we know is the government shutdown. This will also advise some of the policies we're considering and researching. And third, this administration has really taken a look at their administrative power in executive orders, rescissions, cancellations, funding pauses, regulation, and guidance, something that we've actively looked at to make sure that it's in line with Connecticut values and Connecticut procedures and how we administer our programs. And now I'm going to go to Claudia for the next slide.
Thank you. So this is a timeline that we've done to try to break out some of the more immediate changes in the bill versus the things that we have some time through the normal course of regular session and budget and policy development to tackle in the future. Obviously, you can see the most immediate short-term impact was once President Trump signed HR 1 into law, there was an effective ban on Planned Parenthood participating in the Medicaid program. Subsequently, there was legal action and a temporary pause in that implementation, but as of now, Planned Parenthood is effectively banned and won't be able to provide any claiming or billing and reimbursement under the Medicaid program. That is 1-year ban. That's a change from some of the earlier versions. The ultimate bill that passed is a 1-year ban. So they're a major family planning service provider. So we will have to do some consideration of how do we maintain access for our Medicaid population who need those preventative screenings and including cancer screenings and STD testing and other family planning prevention services. The next big thing to hit us this fiscal year will be the legally present non-citizens who earn less than 100% of the federal poverty line. This is typically a green card holder in their 5-year waiting period, 5-year prohibition before they'd be able to be eligible for Medicaid, very low income. Previous to HR 1, this subset was at least able to access pretty significant subsidies on the exchange and be able to purchase subsidized healthcare insurance on the exchange. With the bill passing starting in plan year 2026, so that's January 1, this group of about 5,200, 5,300 people in our state will lose all their subsidies. Second change is a little bit more positive. That's also coming in short order. And that's that HR 1 gives additional flexibilities to categorize all bronze plans and catastrophic plans as HSA eligible, meaning the bronze plan that does have some first dollar coverage can now be linked to a tax-preferred health savings account. We're still exploring how we can use this potential silver lining and make it an option for people who may be eligible for a bronze plan and then compare that with a health savings account to get some more comprehensive coverage. The next thing that's in short order that's happening, and OPM and DSS team are hard at work on this one, is a funding opportunity that was a last-minute negotiation. Senator Murkowski was key in trying to make sure that the rural health providers had some access to financial assistance in transformation. So there was a $50 billion fund set aside for rural health transformation. This is available to all states. The NOFO, the Notice of Grant Opportunity, was published in September, mid-September, September 15th, and the application is due in very quick order. We have a deadline of November 5th. If all goes well, Connecticut believes we may be eligible for approximately $100 million a year for 5 years to invest in some of our rural health delivery system. So we have engaged in a public process. We are still taking stakeholder feedback through October 9th. The last thing that's happening in this fiscal year that is going to be top of mind for all of us is the potential expiration of the enhanced ACA subsidies. I highlighted this one because it wasn't necessarily a change in HR 1, but the fact that HR 1 did not actively extend or make permanent these expiring credits certainly is a cause for some consideration and some planning. So Congress could still act. We're in the middle of a government funding fight where there's bipartisan support for trying to extend some of the enhanced subsidies, but it's unclear where those will continue after December 31st of 2025. You'll also see some of the changes that are happening in the next fiscal year. Those are things that DSS, OPM, and agencies are actively working on through the normal course of budget development, and we'll be preparing solutions in the governor's midterm budget in February. Those include a tighter, more restrictive definition of who qualifies as immigrants for purposes of accessing Medicaid coverage and eligibility. There's also in 27, and we'll get into this in more detail, a lot of plan design changes to the expansion population and a further restriction of which type of lawfully present residents can access ACA subsidies beginning January 1, 2027. So just to give some context, in January of 27, groups such as asylees, parolees, those with temporary protective status, victims of violence and trafficking, and children granted special immigration status, which previously had been eligible and will be eligible in 26, but not in 27 for subsidies, will lose those subsidies. So a tighter definition of lawfully present immigrants who are here who won't be eligible for subsidies beginning January 27. Finally, I want to put on your radar screen a requirement that we're going to have to think through, that a subset of the Husky D population is going to require a cost share, some sort of copay requirement. I note this for two reasons. First, it's important that we figure out some reasonable cost share that actually drives people to better value. We don't want this to be a barrier to care, and there are clear exceptions carved out in the bill. So there are certain services like emergency services, services provided in an FQHC that we cannot put a copay on, so we won't be able to do that. But we need to figure out something between a maximum of $35 for various services and no more than an aggregate 5% of someone's income for cost sharing as part of the Husky D group in October of 28. The second reason why I mention it is the Husky D population is for incomes up to 138% of the federal poverty line. Connecticut, as you all know, because the insurance committee were key champions when we developed the Covered Connecticut program, covers a higher income group. We cover up to 175 with Covered Connecticut. Currently, that program operates with entirely zero premium, zero cost share, zero deductibles, zero copay. So we may need to think about the equity of, if we're imposing a modest copay on Husky D, a lower income group on Medicaid, does it make sense to have a comparable cost share requirement as part of our Covered Connecticut program in the future? Alex, if you turn to the next slide, this is very much, I know that some of you on this committee are also part of the Human Services Committee and well-versed in the Medicaid eligibility rules, but I thought it would be helpful to provide a couple slides to reinforce 2 points here. On slide 5, you'll see Husky has multiple pathways to getting to eligibility, and we also have a complementary state health insurance plan for children, the CHIP program, which has its own eligibility pathways. When we talk about the big changes in H.R. 1, I want to make sure that we're clear. Medicaid has nearly 1 million members. The most significant design changes and eligibility rule changes in H.R. 1 impact a subset of that population, the Husky D. That is the expansion population in Connecticut. And so that's about 310, 320,000 members out of the nearly 1 million. The second reason why I wanted to show this chart is because there's going to be a lot of behind the scenes activity that DSS is working in close coordination with OPM on for making sure that if someone is deemed ineligible because of work requirements or other restrictions on Husky D, these new administrative barriers, we're exhausting every other pathway for eligibility. So for example, someone on Husky D may not have a determination of a disability, but it may be the case that if they're not working and they're on Husky D and they get the formal diagnosis and document their disability, they could move into a different coverage group, Husky C, that doesn't have a work requirement or some of the redetermination periods that have been imposed in H.R. 1. That's important from a fiscal standpoint, less so from a consumer and client standpoint. From the client standpoint, coverage will still maintain. We're going to do everything we can to make sure every pathway is exhausted. And if there's another way to get coverage through a different eligibility group, we're going to make that happen on the back end with DSS. But moving from Husky D to Husky C has a financial consequence as a state that we need to be mindful of. That being Husky D is a 90-10 match. So the federal government pays 90% of individuals in the expansion population and only 50% on Husky C. So there will be fiscal impact, not necessarily a loss of coverage, something that we're going to have to reconcile on the financing side and on the budgeting side, but not as much fear of a drop in coverage. The slide 6 is simply a continuation. Just to close the loop, I wanted to make sure everyone had readily available the full range of coverage options in both CHIP and Medicaid. So with that, if Alex, you can bring us to slide 7. I want to highlight, we've talked about these in brief. I want to go in a little bit more detail here on the Medicaid impact, and certainly Bill Halsey is well positioned to provide some additional details in his presentation. First, we talk a lot about the work requirement. Again, work requirement is going to be imposed beginning January 1 of 2027. We are awaiting an interim final rule. That interim final rule is required by the feds on or before June 1st, 2026. So we still have several months before we get clear guidance from the feds on what the permissible flexibilities are on implementing the work requirement. When we're talking about the work requirement, a couple things are important for Connecticut. The work requirement can be satisfied by work, 80 hours per month, at least. Earnings minimum, so earning the equivalent of 80 hours at the federal minimum wage. The federal minimum wage is $7.25. Obviously, Connecticut's minimum wage significantly higher than that and going even higher in 2026. So someone in Connecticut can work fewer hours and still hit the earnings requirement to satisfy the work requirement. Final point on work requirement is that it's also a community engagement component. So if you don't have a job or can't get a job, you can satisfy this requirement in the hours by working a combination of community service as well as work. So our nonprofit partners may be helpful as we think about implementation of this requirement. The next item is about redetermination. Again, this applies specifically to the Husky D expansion population. Currently, we do redeterminations on a yearly basis. The cadence for doing that will end up being every 6 months, beginning in 27. Administrative barrier, of course, on DSS, more staff capacity needed to quickly move those redeterminations and try to effectively move the paperwork. So we're going to have to be thinking about that. The next item is retroactive coverage. It sometimes is the case that, especially in nursing homes, where there's complexity in trying to make a determination if someone's eligible. In nursing homes in particular, we have to look at any transfer of assets that happened over the several years before. Sometimes that requires a lot of financial and bank statements, and pulling together that documentation can take time. As a result, the federal government has always given states the flexibility to backdate coverage up to 3 months. We're going to have a lot less flexibility when it comes to retroactive Medicaid coverage. The reduction is going to go from 3 months, which it had been, to 1 month for a Husky D expansion population, and from 3 months to 2 months for the traditional enrollees. Again, that's in 2027. The next item we've listed here is with respect to 1115 Medicaid waivers. Connecticut has a few of these. Calvert, Connecticut, in fact, is an 1115 Medicaid waiver. These are innovative waivers where states can independently negotiate some creative ways to deliver Medicaid services or Medicaid-like services for the Medicaid population. They have traditionally been held to a standard of what's called budget neutrality. We would have to show that otherwise we would spend the same or more money, but we're doing it this creative and innovative way, which is spending less money but delivering better health outcomes. That's always been by tradition and precedent. HR 1 takes one step further and sort of formally codifies that budget neutrality requirement. And it adds one other unique piece. It formally recognizes the chief actuary as having a central role in determining budget neutrality. Hard to tell whether this is practically a significant change or simply codifying what had been a longstanding precedent in informal practice. Finally, as we mentioned before, the cost share requirements, which will be imposed October of 2028. And we'd have to have a lot of conversations with stakeholders, providers, impacted communities, and certainly this committee on what's the appropriate level per service type and what flexibilities do we have as a state. Just to recap the Medicaid impact, a lot of this will be system modifications, IT upgrades, figuring out how to operationalize the new work requirements. There is the potential that as people lose Medicaid Husky D coverage and have to go into another coverage group, we lose match. So that's going to be a fiscal impact that we're going to have to try to quantify and look at. And of course, anytime we add more barriers and disruption and people may lose coverage, we're taking money out of the healthcare economy. And that's something that we're just going to have to be mindful of. I'll turn to Zani now for the health insurance exchange.
So for the health insurance exchange impact, lawfully present immigrants with a household income of less than 100% FPL who are ineligible for Medicaid because of their immigration status. We estimate this at 5,400 individuals would no longer be eligible for federal subsidies beginning January 1st. It also eliminates this recapture limitation on excess advance payment of premium tax credits. It codifies the failure to reconcile requirement for premium tax credits eligibility in a single year. That will begin again in January 1st. And then it prohibits APTC and CSR. So APTC is advanced premium tax credits and cost sharing reductions in CSR for individuals that would have been enrolled in a Medicaid but not meet work requirements. That would be in January 1st, 2027. And then Claudia will go over the anticipated expiration of enhanced premium.
So as we started at the top, we're all anticipating and seeing how the government shutdown will resolve. Certainly a live issue that is under consideration is whether to continue the enhanced premium tax credits that were a COVID era, product of the COVID era, and it extended in the Inflation Reduction Act. Those are set to expire at the end of this year. I would think of this as 3 different cohorts of people that are impacted potentially if these tax credits go away. First is the covered Connecticut population. We are fortunate in Connecticut that we have an approved waiver through the end of 2027 that covers people under 175% of the federal poverty line with a zero copay, zero deductible, zero cost sharing option called Covered Connecticut. So these individuals, about 50,000 of them, are going to be shielded from any of the expiring tax credits. The state and federal government will pick up 50-50 the difference of the reduced subsidies that the ACA is going to now provide. But from a client perspective, from a consumer perspective, the covered Connecticut population will be maintained and have the coverage they have without any additional costs on them. It's expected to be about a $30 million cost over the biennium for the state share to pick up our portion of those expiring subsidies. The second cohort are the traditional group of 100 to 400% of federal poverty line that had Obamacare subsidies under the ACA. They had enhanced subsidies for a period of time. Those individuals will return back to the Obamacare basic subsidies. They will still have subsidies. Very important to reinforce that even if these enhanced subsidies go away, that large cohort of individuals will still have some subsidization. It's just that they will have to pay more for their coverage. The final group is the subsidy cliff group. So about 28,000 individuals did not have coverage or subsidies under the original Obamacare. This was sort of a design flaw in Obamacare. Once you hit over 400% of FPL, you got no assistance on the exchange. That cliff is reinstated if the enhanced subsidies go away. I worry about this group because this is a group that loses all financial assistance. So we'll have to figure out, we've been trying to have conversations with the carriers who have been really helpful at helping to dig into what does this population look like and how price sensitive are they? Are they likely to drop down to maybe a bronze or a silver? Are they exiting the market? Are they high need, high healthcare costs and will stay on because they absolutely need it, but may impose an additional risk on our total health insurance pool. So this is a moving target and one that we're going to have to get a handle on. In total, the loss of subsidies, and this is Access Health had provided us with this top line number, about $350 million. I will note that's estimated on the 25 premiums. We all know that there have been recent rate hearings and increases to those. So this estimate is likely to go up. It's not likely to go up by the simple math of take the percent increase and just plus it up, because the subsidies for those people between 1 and 400% increases as the premium moves up. So the premiums will sort of trigger some additional subsidies as the silver plans increase in cost as well. I'll turn it back to Zani for short-term and long-term policy considerations.
So as we mentioned in the beginning of the slide, we've been working with our agencies, stakeholders, and other partners to really try to, one, scope down and understand what's currently happening at the federal level and understand the impacts. Two, try to delve into some just early understanding of some policy considerations with our partner states of how they're addressing this. So we've broken them out to short-term and long-term, just beginning ideas of what pathways to consider. All of these have to be understood in fiscal considerations, how they fit in Connecticut's policy framework, and these are just things we're considering. So, partial short-term backfill of exchange subsidies, enhancements to the Business Plus formerly known as ICRA, leveraging new flexibility for bronze plan eligible for HSAs, and exploring different pathways for eligibility of services. And then the next slide for long-term, examining long-term strategies for insurance affordability. So this is something that this committee has always been good in working with us on, and also the governor has worked extensively for the past few years on examining reinsurance. We're exploring potential funding source to fund reinsurance, and looking at the feasibility of a waiver, Covered Connecticut, refreshing the Covered Connecticut waiver and ability to look at how we deliver that program, and then pooling small employers and nonprofits and see how we can enhance the services of their health insurance. These are just ideas that we're examining, but also in coalition with our states, because a lot of it also depends at the federal level and how they take action in the next month, and also how their rules and regulations will be adapted as we wait for final rules and clarification from them. I'll turn it over to Claudia on next steps.
So that's a perfect segue. Obviously, we've indicated a few places where we have unclear guidance or still to be developed federal rules and rulemaking. So our agencies and the executive branch is committed to being active and engaged in that process. Where there's opportunity for public comment or feedback from the states, we're working with our peer states. Also looking to leverage opportunities so that if Connecticut is having to do this mandate or impose a new work requirement, we're not doing so in isolation. There's an economies of scale here, and I know the governor has encouraged us to try to figure out, is there a regional strategy where we could share some of these administrative and overhead costs, since we're all building the same system or a similar system, and those conversations are happening now. Obviously, as we talked about from that first slide, we're looking very particularly at the FY26 impact and what executive branch actions and administrative actions we can take now to be able to get ahead of some of those changes. And then a lot of this, in particular, the long range healthcare cost drivers and how we as a state want to tackle that, is going to be part of our budget adjustments and the governor's bills to be presented in early February. That concludes.
Great, thank you. We'll open it up to questions from the committee. I'll take the first stab here. So it sounds like the legal immigrants, those with the green cards, are the first group of people that we have to be the most worried about, that 5,400. What are the recommendations for that?
Great question, Representative Wood. So I think the strategy here is multi-pronged. We recognize that a lot of those people are going to be probably in their waiting period to Medicaid. So we're going to try to figure out and identify them early so that if they're 4 years plus in, Medicaid may be the best strategy, and just getting them early identified and moved quickly into Medicaid eligibility is going to be an important part of our strategy. The second thing here, and this is typical, this is kind of one of the weird quirks of HR1, is that it has these weird unintended consequences. So whereas someone under 100% of FPL loses all subsidies, if they made 101 of FPL, a little bit more money, they actually can get all their subsidies back for a plan year. So part of this strategy is working to connect people to work. If they're working a gig job and they can pick up an extra shift, that might unlock tens of thousands of dollars of subsidy, and that might be the best pathway for them to actually get healthcare coverage. Other than that, as the ultimate backstop, we're looking at how do we shore up our FQHCs and our safety net providers, right? So some people in this state aren't going to have insurance, and it's just going to be unaffordable. But we are fortunate to have a pretty robust network of FQHCs that charge on a sliding fee scale. So if you have insurance, they'll bill insurance. If you don't, it's based on your ability to pay, and they'll provide coverage. So trying to figure out how we can tap into those safety net providers and shore them up to provide some good basic care. I would say that's the three-pronged strategy that we're thinking through now.
Yeah, that's great. You kind of answered my second question, which is you're going through what can be done via executive order versus what needs to be done through the legislature. So it sounds like you're working on that now. Obviously, wherever we can help, we want to be involved. And then it's always nice to see you support a pooling option, which the committee has put out for 4 years in a row. In addition to allowing pooling, creating more opportunity in this space, more competition. And this is a question that I'll be asking the department and Access Health. How are we getting more carriers to, come do business here in Connecticut? I hope we look at those market factors too. If there's gig employees that, may lose their coverage or may lose their subsidies, they could join an association of some sort or a chamber of commerce and pool together. If they're consulting for nonprofits, they can, pool in that space. The nonprofits are also, it's going to be the number one issue of next session is how do we ensure our nonprofits, both healthcare, liability, property, auto, healthcare is a major part of that. So we have constantly been putting out solutions, and we will continue to do that. And we hope that we can work with you in a more collaborative way to make some of these things happen. So I'd love to hear your comment if you're thinking pooling versus private or pooling versus public.
No, I just wanted to say I think that's a great reflection of some of the conversations we've had. One thing I'll note is that sometimes changes like this create a different value proposition for older solutions. Like we had these solutions, including reinsurance, and they sort of stagnated a bit. I think that the idea that potentially those earning above 400% of FPL, that 28,000 group, is not going to have any subsidization. The one thing we can do, reinsurance is helpful for the unsubsidized. So as the unsubsidized portion of our exchange grows, something like reinsurance becomes a lot more interesting and compelling of a case. Same to your point about some of the pooling strategies. We've been fortunate up to now that our exchange has been very heavily subsidized. I think 90+% of people on the exchange get subsidies, and for the past several years, enhanced subsidies. As those go away, we may need to revisit some of those other strategies that now become a lot more compelling. So I appreciate your ongoing efforts to work with us and other stakeholders and try to get us to a good outcome in the next year.
And for everyone in the room, I did invite reinsurance to come present during the public comment, but it was very last minute. And we do have a meeting set up, our committee, with reinsurance companies just to kind of dive into that. And I'll pass that invitation along. Other questions, Representative Meskers?
Thank you very, very much, Madam Chair. So, Claudia, I just wanted to get deep in that conversation. When we're talking about reinsurance, we're thinking potentially, in addition to the chairman's commentary on pooling, the reinsurance would be a catastrophic loss or an underwriting of some of the risk to try to reduce the overall risk of the pool and reduce premiums? Is that what we're thinking?
Yes, thank you, Rep. Meskers. So you may recall when the ACA was first initiated, it had a reinsurance component, and that was a key piece to sort of keeping prices in check for that early period of implementation. Since then, a number of states, I want to say 7 or 10, have done reinsurance type programs, and it can be designed differently. It depends what the attachment points are and how we choose to design it. But generally speaking, the theory is you take the highest cost claims off and you sort of socialize those and pay for those outside to reduce the cost on the insurance premium. So it's taking those high cost claims at various attachment points and paying for those through the reinsurance.
So you're hoping in that case, if I may follow up, you're hoping on that case that a reinsurance policy might work as a generalized subsidy to the exchange or to people participating in the exchange versus attempting to do some marginal or dollar for dollar match on the loss of this tax subsidies from the federal government. Is that correct?
Yes, that is a correct read on that one. And to your point, because it helps the entire marketplace, what states have been able to do is basically go to the federal government and say, hey, we're doing reinsurance and it's actually reducing the costs across the exchange, thereby reducing the federal subsidies for that under 400 population. Can you give us back that money? So through these 1332 waivers, the federal government has been able to give, 67 to 70% in some cases of the costs of reinsurance. We make that case, it's cost avoidance to the federal government because if the costs increased on the exchange, the subsidies for that large component of the exchange would have increased. So we're taking that savings that the federal government would have accrued and asking them to put it to help pay for the reinsurance. So that's a key in our thinking of how do we leverage federal funding. If the expiring credits are going away, we need to be smarter about where we take on more federal dollars to support the end goal of reducing costs.
And the other piece we'd mentioned was potentially subsidizing further or helping the FA the healthcare clinics, basically.
Yes, that's certainly right.
Okay, thank you very much. No further questions. Thank you, Madam Chair.
Thank you. We have Representative Nuccio followed by Representative Berry.
Thank you, Madam Chair. And thank you, Claudio. I just really want to start out by saying it is so refreshing to have a meeting with the administration here looking at all of this. That is actual facts and not rhetoric. So thank you so much for this presentation. I plan on using it multiple places and really kind of showing people what's happening. So I appreciate that. And I just want to say what you were just talking about with Representative Meskers, there's going to be some very happy Senate Republicans who've been pushing for reinsurance for my entire time here in the legislature. I do have a couple of questions about that, though, being pretty intimate with the 1332 waiver and reinsurance programs that are currently being administered across the country. Typically, the reinsurance will come with some sort of an assessment. Now, the state government's going to have to pay for part of it, and most other states, they really kind of look to kind of backfill that through state assessments, which we all know will impact our fully insured population. Have you looked fully into what we think this is going to cost, how we are going to fund it, and whether or not it's going to result in a further assessment on fully insured business?
That's an excellent question and one that we have sort of previewed here in our long-term strategies. Is the big question around reinsurance is the pay for. So what we don't want to do is assess the industry at such a degree to pay for the reinsurance that it's marginal return on investment, right? If we're going to charge them more to pay for the reinsurance, then the reinsurance is going to bring it down. We're not going to be much better off than we are. So we do need to be thinking creatively, and that's the exercise that we're going through. Zani and I have had several conversations with a handful of the states, Colorado, I think Vermont, a handful of others that we have scheduled in the coming weeks to figure out what are the other leverage points that we can do to pay for that reinsurance investment in addition to the federal match. But you're exactly right, Rep. Nuccio, and I will enlist your help if you're around and able.
Claudio, for you, I am always around and able. Between the insurance side of the reinsurance here and also the state budget side, I am very anxious to sit down and talk to you and help come up with some solutions for it. Also, I'd like to say, as Rep. Wood said, I thank again the administration here for, kind of backing what we've been trying to work on for the last few years, which is, the AHP plans, trying to kind of group small businesses and such together for better rates and that. I think that is definitely something we should be looking at. But in regard to a couple of the things that you had, I was writing down kind of furiously. I know we're getting the presentation, but I was still kind of writing my notes down kind of furious here, right here. And you're kind of mixing. So you've got the Medicaid and the insurance on here. So I feel like that kind of opens us up to be able to ask a few questions on that. In regard to the new HSA allowment for bronze plans, this is something I don't know, so you can definitely educate me on it. Do we not have the ability for HSAs through all levels of the plan? Was bronze just excluded and we have it on others? Because that is definitely a way where an employer could help to offset the cost of a premium.
And Access Health is probably able to answer more details on this one, but basically, our understanding is that we had bronze plans, but not all bronze plans were eligible per IRS rules to meet the requirements for being attached to a health savings account. Some of it has to do with how much first dollar coverage and pre-deductible benefits were provided. So this is, we think, a potential game changer in that now you can have a little bit more of a comprehensive plan actually meeting the IRS standard that may not have previously done. I'll leave it to Access Health to talk through which of the current plans. We do have some that are offered on the exchange that even before HR1 would have qualified for an HSA, but this just makes it more categorical and expansive that the bronze plans are.
I think that's a really good opportunity for us. It's something we should definitely be exploring, and how we can try to incent businesses to kind of help offset the cost of insurance through utilizing that HSA through value-based payments that they can make to their employees. So I think that's excellent. In regard to the rural hospitals grant, you said we're expecting hopefully about $100 million a year for 5 years. Can you tell for us which rural hospitals would qualify for this? And secondarily, how would UConn buying up like Day Kimball, Bristol, and Waterbury? I don't think Bristol is considered rural, but I know Day Kimball definitely is.
Yeah, it's a fantastic question. So here's how I will say it. The component of the grant is divided into two parts. One is based on equitable share, based on having an approved application. That's where we think we're going to get the most of our money because Connecticut is not very heavily rural by the federal standard, but we do share in that equal distribution of half of the fund. The other half is based on a competitive basis, essentially whether Connecticut signs up for various initiatives or policy changes. For example, one of the requirements is whether the state makes a commitment to reinstitute the presidential fitness test exam in schools. If a state chooses to do that, writes it into their application, then they would end up getting additional funding as part of the rural health grant. So I would think of it not as a fund to sort of bail out or support direct payments to hospitals or health systems, but more how do we transform the delivery in rural communities and in underserved communities throughout the state. So right sizing, your comment at the top about Day Kimball and figuring out a right sizing strategy for what presence makes sense for Day Kimball and how does it work in affiliation potentially, and how can this funding help support the necessary IT, cybersecurity, interoperability of health information exchange to make Day Kimball an attractive partner with other independent hospitals or other community partners is certainly in scope and something that we're looking at. The other ideas are around how do we deliver better chronic and ongoing case management and disease management. So we've had some conversations, and for example, DSS has done a two-part feasibility for how do we make sure elders have more opportunities for comprehensive care to stay independent in the community and avoid or delay institutional care. And there's practices in a number of states, I think 40 so states have what they call PACE programs, these all-inclusive integrated care delivery. Can we think about doing some model like that in Eastern Connecticut or Northwest Corner where the demographics do skew a little older, and if we can keep people healthy and living independently, that's going to be a transformational thing. So the feds have really encouraged us to think transformationally about this, do things differently, more effectively, build out capacity for telehealth, build out interstate licensure compacts, and making sure that everyone is working to the optimal of their training and expertise. So can pharmacists, I know that the insurance committee is leading a work group. There's been active conversations with this rural health fund about, can we let pharmacists do and get reimbursed for more primary care and screening activities, and what does that look like? All of this is sort of in scope, but very much transforming and doing something different with the healthcare system, which is exciting to me at least.
Yeah, so I think all of that's great. I'm all on board for all of that, but I think my concern is, you say Northeast, Northwest. So I think Day Kimball, I think Johnson, I'm thinking Charlotte Hungerford in the Northwest, right? These are definitely rural areas. But will it matter that those hospitals are owned by Hartford Hospital or UConn? Like, is it proximity rural, or is it you're owned by a massive hospital conglomeration so you don't qualify?
Our understanding is that states have pretty wide flexibility in here on how to reinvest the money. So the money is allocated based on rural and how much rural we have, but then we can direct the money as we see fit. So it doesn't have to exclusively be redirected into the rural areas. And I think whether Hartford owns any of those does not prohibit us from making investments in hospitals that they own that are in rural communities serving rural patients.
So, yeah, that I think is a little kind of worrisome for me then, because if we're saying it's not necessarily going to go to the rural hospitals, that means it can be redirected to Hartford Hospital or St. Francis. So I would like to really kind of understand how we're going to do that as it comes through. And I know that's fairly new right now, and it's just in development. So I think those are conversations to be had. I have a lot more questions, so I guess I will wait to see if anybody else has any questions to go. I'll have one more and then I'll come back because I definitely have more questions off of the presentation that you gave. The last question that I will use at this time is basically for the Husky depopulation that you talked about. Thank you again for iterating that these changes are just against Husky D and that no, babies are not losing their coverage here, contrary to what people will say. Husky D, that population, the 19 to 64, do we happen to know right now what is the percentage of that 313,000 people who are already currently working or just at the lower income levels?
I'll jump in there, Rep. Nuccio. Hi, good morning, Bill Halsey. I'm the Medicaid
Bill.
Director at DSS. So we are working through a lot of that data right now, Rep. Nuccio, and also I was going to say in my opening remarks, there are exemptions to the work requirements
Yes,
that
there
we
are.
are also working through. So we are trying to do kind of a line by line analysis of who's working in the Husky depopulation, how much are they earning, where that money is coming from, and then all of the exemptions and who would meet those exemptions. So I don't have a number for you today, but that is the level of detail that we are trying to get to of the, say, 313,000 members. What are we left with that would be required to do the work requirements? And so we're working through the income and we're working through all of the eligibility populations to see if we can kind of winnow that down to a number that we feel comfortable sharing.
Yeah, I know I've asked for that before, so I'm glad to hear that you guys are still working on that. And is there likelihood to be able to switch them from Husky D to covered CT? Is that something that we could look at doing? The people who would possibly fall off at this point?
No, so that's clear prohibition. That move from Husky D to covered Connecticut would not be allowed. The reason being, HR1 is very clear that if someone would have otherwise qualified for Medicaid, but for the work requirement, community engagement requirement, they then are not eligible for subsidies on the exchange. One of our requirements on the 1115 for covered Connecticut and statutorily is that to be eligible for covered Connecticut, it's 175 FPL, and you have the ability to qualify for all the subsidies and all the cost share reductions. So if you don't have that ability to leverage the subsidies and the cost share because of HR1, you don't meet the eligibility for covered Connecticut. The population shift that we talked about before to Husky C, if there's a determination of disability, is in play, as may be other coverage groups. Bill, I don't know if you
Yeah,
want to
no,
add
I would
anything
agree
more.
with that. The movement within the Medicaid eligibility groups is possible, but they cannot switch over to covered Connecticut.
Okay. All right, and then I'm going to narrow this down. The last question that I have is you did not mention the regular Obamacare FPL basic subsidy, the 100 to 400. How many people that was being affected by that?
I'm gonna either defer to Access Health because I don't want to misspeak, or I will follow up with you. But it is a significant portion of the population. Just by rough math, if you take out the 28,000, we're about 150,000 on the exchange. You minus the 28,000 and you minus the 5. I would suspect the balance is your question. I just want to confirm that.
Thank you. I appreciate that.
Representative Barry.
Thank you. On slide 8, the impact on the exchange, bullet 2 references the elimination of the recapture limitation. Can you explain what that is?
I will try, Rick Barry. So prior to HR1, there was limits on recapture of over payments. So for example, less than 200 FPL, the maximum repayment recapture for a single taxpayer was 375, and the 750, and for a single taxpayer it was 375. All the under 400 FPL, those were all capped. So 300 to 400 was 3,000 for other taxpayers on a single was 1,500, and over 400 was not capped. So that removes all the caps under 400 FPL. So if you overpaid, then they could, if you don't mind, sorry.
No worries. So Zani's talking about the practical reality. One of the benefits of the APTC is that it's advanced. You don't have to wait till the end of the tax year to claim it. So we're going to allow you to estimate. So that advanced premium tax rate is based on your best estimates for how much you would have earned and what your family size would be and all that stuff. And so when you're claiming that credit, at some point you have to reconcile how much did you estimate and were you off, and were you eligible for less subsidy than you really should have gotten? And up till before HR1, we basically said, yes, you probably ended up with an estimate that was very favorable to you. So you got more advanced premium tax credit than you really should have gotten. But we're going to limit how much someone who's lower income has to cough back up, how much they're going to claw back from you. And those limits were set at the inflection points that Zani mentioned. Less than 200% of FPL, an individual wouldn't have to pay more than 375. So now thinking about that, I think it has a couple consequences, right? It could be a deterrent and a chilling effect if people know they're on the hook for all of it without any sort of safe harbor or protection. Two, I mean, it very well could be the case that at the end of the year, people are having to pay lots more back. So on the front end and on the back end, this is something that we're probably going to have to think through.
And when does that go into effect?
That's 26, January 26.
Okay, thank you.
Any other questions? Okay, I'm safe to assume, Bill, that you are presenting with OPM, or do you have a separate presentation?
We have a separate presentation, so I'm going to ask Jennifer Marsacci to come up and join me. Also from DSS, she's going to go through the covered Connecticut component of
Great.
the presentation. And so I just want to say thank you to Claudio and Zani for running through much of the DSS or Medicaid component. I think we're going to ask David Seifel to send this committee all of our presentations that we've done to MAPOC on HR1 related to Medicaid. I think that would also be very useful to this committee. So, and my understanding was that we were going to do a presentation on covered Connecticut, which is the Medicaid 1115 demonstration waiver as part of this. So I'll turn it over to Jennifer.
Thank you, Bill. Thank you, everybody, for having me today. If somebody could advance to the next slide, please. So right here on this slide is a member profile for Covered Connecticut members. On the left side of the screen are just some highlights of the population and what their makeup is. Currently, we have 50,184 members enrolled in Covered Connecticut as of August 31st, excuse me. As of September 31st, not referenced here, we have 51,762 members. Of those members, 32% of the total Connecticut marketplace, they represent rather 32% of the total Connecticut marketplace enrollment, and 35% of the marketplace enrollees that receive subsidies are enrolled in Covered Connecticut. And then you can see the breakdown by gender and by age. On the right-hand side of that slide, you can see the enrollment distribution by county. It largely makes sense that we have concentrated enrollment in Fairfield, New Haven, and Hartford, and then outlying counties, lesser enrollment. Down below in the enrollment distribution by FPL, you can see between 138 and 175, we have approximately 61% of our members in those income bands. And that's important because those are the income bands that are largely affected by the elimination of the EPTCs. You can advance to the next slide, please. This is the Covered Connecticut budget. On the left-hand side of the slide, you can see the total spending for state fiscal year 2025, which was 56.9 million gross, and state share was 28.5 million. Below that is the PMPM cost breakdown, which is $113 per member per month as it currently stands. On the right-hand side of the slide, you can see the elimination of the enhanced premium tax credits. We're going to increase program costs in SFY 2026 by 7.2 million and SFY 2027 by 22.7 million above what we've spent in SFY 2025. And finally, these are the impacts to the marketplace rule changes and how they affect Covered Connecticut. So just listed here, the end of coverage for deferred action for children arrivals. So we have 144 DACA recipients in Covered Connecticut. Lawfully present immigrants, I know OPM shared a number of 5,400. I have a number of 5,300, so there's a slight deviation there, but between 53 and 5,400 are lawfully present immigrants. And then other changes that'll impact the program. You're ineligible for premium tax credits if you didn't meet the work requirements. In Medicaid, you're not eligible for tax credits on the exchange, so you wouldn't be able to enroll in Covered Connecticut. And then requirements to submit income verification if there are no tax data available. They'll have to attest to income that would make them eligible for a PTC, but federal databases that show income below, that will likely decrease marketplace enrollment due to the failure to complete the verification process. I'm sorry? Oh, sure. So on slide 2, if you could go back, the budget slide. I think it's, I'm sorry, slide 3, forgive me. So just to note here, with the elimination of the enhanced premium tax credits, the average Covered Connecticut premium is going to increase by $71 per member per month. And that'll be passed on, the full cost, to the Covered Connecticut program. And not to the member, as the statute currently does not allow a member to pay any cost sharing, and the waiver does not allow any member to pay any cost sharing. So any cost sharing would require an amendment to the waiver and an amendment to the state statute.
So just to reemphasize that, I think Claudio mentioned this. So in at least the Covered Connecticut program, the 50,000 or so will be shielded from that impact on January 1st.
Are you ready for questions? Are you done? Okay. Thank you very much. So yes, I'm glad you ended on that. So we have through we have January 1st, 2027 for that impacted population. Is that correct? Or is it through 2027 that they'll be shielded?
We have to submit an amendment to the waiver
Yeah.
in 2027. I'm sorry, in 2026
Okay.
for approval in 2027. So depending on what we request for an amendment, some level of cost sharing, yes, they'll be shielded.
Okay. And can you just explain to the committee and those of us that, don't do this every day, how the Covered Connecticut program is different than Medicaid?
The Covered Connecticut program leverages the subsidies and tax credits on the marketplace, and then covers the premium after tax credits are applied. So, say somebody has tax credits that only give them a $10 premium per month. The state covers that, and then we receive 50% match on that from the feds. But it actually ends up being about 90% match when you factor in the advanced premium tax credits and subsidies, cost sharing reductions on the exchange.
And how is the state engaging with this population? My congratulations, I see, more members were added, the most recent number. I mean, it's really nice and refreshing to see that, even though we're talking about, how to keep this ship moving going forward. But how is the state engaging and signing people up for the Covered Connecticut program?
I don't want to speak for AHCT. I know they do a lot of outreach and marketing, especially during open enrollment, and they have various campaigns on a myriad of social media platforms. DSS works in partnership with OHS. OHS was mandated to do the outreach and engagement for the program, and they were allocated funds to do that. So we recently launched a marketing campaign in September to support outreach and engagement. We also contract with community navigators through a statewide CBO to do outreach and engagement with Connecticut residents.
And that kicked off. Yep. Great. Thank you very much. Any other questions from the committee? I don't see any, so you get off easy. Thank you so much.
Thank you.
All right, next up we have Susan Richby from Access Health CT.
Thank you very much, Chairwoman Wood, and thank you to the committee for inviting us here today to provide you with information on all of these federal changes. First, I just want to start with an apology from James Michelle, our CEO. He had a conflict, so he was unable to attend, but I am here to provide you with all the information and answer any questions you may have. So if you could pull up our slide deck, please. Thank you. Next slide, please. Next slide. So as Claudio mentioned and Zanny, we've been talking today, there are a number of federal changes coming to the marketplace, as well as Medicaid, coming from three different sources. The One Big Beautiful Bill, also known as HR 1, that was signed into law on July 4th by President Trump. The final rule issued by the U.S. Department of Health and Human Services on marketplace integrity and affordability, and that was published on June 25th. And then also a very important topic, the likely expiration of the enhanced premium tax credits that went into effect in 2021 under the American Rescue Plan Act and were continued in 22 through the Inflation Reduction Act through their current deadline of December 31st, 2025. Next slide, please. So I'm going to focus here on the changes for 2025 and 2026 right now, the most immediate ones impacting us. I know OPM also mentioned changes for 2027 and 2028. So as we've been talking about, there is a big impact for the lawfully present immigrants who are not yet eligible for Medicaid and have income below 100% of the federal poverty level. And under HR 1, they will no longer be eligible for financial assistance through the exchange starting January 1, 2026. This was an exception. Normally, the floor for eligibility for premium tax credits is 100% of the FPL. Also mentioned today under the final rule, The DACA recipients who recently gained eligibility to purchase insurance and get financial assistance through the exchange, unfortunately, that has ended as well. We just ran those terminations yesterday. Their coverage ended yesterday as of September 30th, 2025, and that was 144 people. We did not have a large population here in Connecticut, though some other states did have much larger groups. Also, one of the items that's going into effect right away, that went into effect right away, was the elimination of the special enrollment period for customers with income below 150% of the federal poverty level. Fortunately, in Connecticut, we do have the Covered Connecticut program, which has rolling enrollment throughout the year. So that really has protected that population. Also, one of the other items is a shortening of the 150-day period that consumers would have if they needed to send in documents to verify their income. It's going back from 150 days to 90 days. A few of the other requirements that were in the final rule are currently subject to a stay in City of Columbus versus Kennedy, and those include modifying the verification process to determine eligibility related to income in a few different areas. And also, there was something that was in the final rule that would have allowed carriers to require consumers to satisfy past due premium from prior years before accepting or applying a payment to their effectuation for their plan for the new year. That is also subject to the stay. And then obviously the one that probably has the broadest impact across the market is the likely expiration of the enhanced premium tax credits. Overall, this means less financial help for Access Health CT consumers receiving this premium assistance. We do want to remind people, as has been pointed out here already today, that not all financial help is expiring. This is the enhanced tax credit structure that went into place in 2021. The original ACA subsidies would still be available if the enhanced premium tax credits did expire at the end of the year. It also reinstates the cliff at 400% of the federal poverty level to receive financial assistance. And it also, as DSS has pointed out, and OPM, that it will increase the state's cost to fund the Covered Connecticut program. Next slide, please. So looking at all of these different factors, Access Health has looked at our enrollment and tried to estimate what the potential impact of all of these different changes are. And over the next 9 years through 2034, we estimate that 30 to 35% of our currently enrolled population could be uninsured during that time period. And just to point out, this year, we have been fortunate to have the largest population enrolled in coverage through the exchange. Right now, there's over 158,000 people enrolled. That is a very large number based on past enrollment. So that is the potential risk there. But as always, we just want to keep reiterating that I was still on that slide, that there is still financial help available. So as we've been mentioning, the likely expiration of the enhanced premium tax credits is the broadest impact across the market. There are currently over 142,000 customers receiving financial assistance, and over 50,000 of those are in Covered Connecticut. The numbers today are actually over 143,000 receiving the premium tax credit assistance. And as Jen pointed out, over 51,000 are enrolled in the Covered Connecticut program. And there are 28,000 of those customers that have annual income over 400% of the federal poverty level. So that is the group that would lose all financial help if the enhanced premium tax credit structure was not extended. Next slide, please. Thank you. Something we've also mentioned today is the impact going in 2026 for those lawfully present consumers who are ineligible for Medicaid due to immigration status and have income below 100% of the FPL. they will no longer be eligible for financial assistance. And right now, that is about 5,300 consumers. Next slide, please. Another item from the final rule that impacts cost for consumers is a change to the premium adjustment percentage methodology, and this impacts a number of different items. And specifically for consumers, it impacts the maximum out-of-pocket amounts that plans can charge. Carriers did file a few non-standard plans for 2026 using the higher maximum out-of-pocket amounts in anticipation of the rule being finalized, which it was. These increased limits, I will point out, represent a 15% increase compared to the 2025 limits. So that is pretty significant. They also would like to note that Access Health CT uses standard plan designs and requires the carriers to offer the standard plans in addition to non-standard plans at the bronze, silver, and gold level, and all of the standard plans for 2026 use the lower maximum out-of-pocket limits from before the premium adjustment percentage was changed. Next slide, please. So something that OPM also mentioned is the change starting for tax year 2026 in these consumer protections, the repayment caps for excess advanced premium tax credits that consumers may have received during the year. Up until this point, lower income consumers with income below 400% of the federal poverty level had different thresholds for the repayment caps to protect them from having to pay a large amount of money back to the IRS if they did receive excess premium tax credits during the year. All of those protections are going away. So this is one of the items that Access Health CT will be really messaging to consumers, that it's more important than ever to make sure that you estimate your annual income as correctly as you can. And if it does change during the year, that you come in right away and make the updates to change that. So you hopefully don't wind up in a situation where you have repayment responsibility. Next slide, please. Finally, all of these changes, what is Access Health doing in response to it? As always, our focus is always on Connecticut residents and providing as much help and information as possible. Our Health Equity and Outreach Department will be using a community-first, data-driven approach. We have added 4 new mobile enrollment specialists for this coming year, so we'll have more in-person assistance available. We host enrollment fairs throughout the state to provide this in-person assistance. We know some consumers aren't comfortable with either doing it online themselves or going through the call center, and they really want that in-person help doing this. So we do provide that all over the state. We've also increased our navigator presence, activating our trusted resources in the community. We have 6 navigator organizations for this year, and we also have hundreds of community organizations that we work with throughout the state. Our marketing team is focusing on clear messaging. All of this is entirely, a lot of information and very confusing for consumers. And we know through some focus group work that we did over the summer, people don't necessarily want to know the nitty-gritty policy details. They want to know, how does it impact me in dollars and cents? So we are focusing on clear messaging to consumers using mail, email, and text messaging. Also, our mass media campaign, as we always do, will be including this information. And our most important message for 2026 is to really shop and compare your options. We have 22 plan options available. The plan a consumer was in for 2025 may not be their best financial option for 2026, and we want to make sure that they know they really should, use that free help, use a broker, and shop and compare and find the best option for 2026. As always, all help is free, in person, as I mentioned, online, and over the phone. Next, our operations and technology teams have also had to make changes in response to these upcoming federal changes. We anticipate increased call volume to our call center. So our call center will be increasing staffing to meet that need. And also, fortunately, we have changes to our enhanced interactive voice response, which is an IVR system that were actually put into place this July. So it's been very good timing for us. And this allows us, our new IVR has more languages available. So a consumer just needs to speak in those languages. Those are Haitian Creole, Portuguese, Ukrainian, Arabic, and then English and Spanish. And those are based on the languages that are, spoken the most by people in the state. And also the new changes allow them to text helpful links to consumers with information. And of course, with all of these changes come a lot of changes to our online system that we've been working on. If you go to the next slide. So there were questions sent to us, next slide, please, by the committee. So we also wanted to take some time to respond to those specific questions. What is the written timeline for communications to consumers? So we've got a chart here showing you those, and the items that have an asterisk are letters that will be received by all customers. We have things going out to everybody and things going out to specific special audiences depending on their situation and their need. We started this communication early. We sent a postcard out in August to tell people federal changes are coming. For the DACA recipients, we had a special letter that went to them in addition to their system notice that went out this last month, in September. And then also in early October, we have a letter going out detailing the federal changes that is going out to everybody who is currently enrolled. And then we also have a special audience letter going out to those immigrants with the income below 100% that will be losing eligibility in 2026. That is going out in mid-October. Turning to the expiration of the enhanced premium tax credits. We have letters going out to everyone receiving that financial assistance also in mid-October, and then a special letter going out to those folks that would lose eligibility with an annual income of over 400% of the federal poverty level. And then finally, we have a normal notice that goes out to consumers in October. It's going out about October 20th, which we refer to as a projection letter, which tells people what they're enrolled in now and what they'll be enrolled in for auto renewal for 2026. They always have the option to change their plan, but this just gives them all the information on the new premium rates and their financial assistance for 2026, and we will be adding an insert about the expiration of the enhanced premium tax credits in all of those projection notices. You turn to the next slide, please. So what is the message that we're sharing with consumers about the subsidies? As we've been talking about today, there's a lot of confusion here, and sometimes when people talk about this, they say the subsidies are going away. We want to make sure that people understand that the original ACA's subsidies are not expiring, that all of this discussion is about the enhanced subsidy structure that's been in place since 2021. And as I've been mentioning, the best option for consumers is to shop and compare plans to find the one that's best for them and their family, their health needs, and their financial needs. We have a very strong group of certified independent brokers available. Over 800 have been working with us. Brokers are a big part of our consumer assistance, and that help is free. And we have tools on our website to help consumers find a broker in their area. And as always, all help is free online, over the phone, and in person. And I believe, as the Department of Social Services has done, we have also put up a page on our website listing all of the information about these federal changes, and that is available in English and in Spanish as well. So consumers can go to that page as well to find information generally. You go to the next slide, please. How will consumers be informed if the enhanced subsidies are renewed or not renewed? We're going to use our primary messaging channels, direct mail, email, and texting if they've opted in to receive digital communications, and also using public relations efforts through news articles. secondary messaging channels that we can update very quickly if we need to mid-campaign, if the subsidies are extended after open enrollment starts. We use paid and organic social media, online advertising, paid search, display, and native ads, digital billboards, and also when we were recording our mass media, we recorded different versions of voiceover edits to TV and radio ads so that we are prepared if something changes after open enrollment starts and we want to quickly update the messaging. You go to the, and that is a copy of the postcard that went out, sorry. You go to the next slide, please. What will a consumer see in their January bill? This is at the discretion of the carriers, but customers can anticipate seeing a bill as they usually do. The bills list the total premium, the subsidy amount, if it's applicable to that consumer, and then the consumer portion of premium due. Next slide, please. What is the role for the broker, call center, and carriers in communications? Brokers have an indirect role in communicating the impact of the enhanced premium tax credits if they expire. More specifically, brokers will be working with customers to help them choose the best plan that works for them based on the financial help that's available, the family's health needs, and their budget. Because an expiration of the enhanced subsidies will impact the budget considerations, the brokers are being educated about these federal changes so they can explain why the costs may be more expensive for consumers for plan year 2026. The Access Health CT training team is hosting webinars, as always, but specifically this year also to educate brokers as well as our certified application counselors, navigators, and community partners on these federal changes, along with enrollment and eligibility system changes. Likewise, the call center representatives are being trained to prepare for open enrollment, which includes materials on the federal changes. Next slide, please. I think this is a little similar. What is the role for broker, call center, and carriers in communications? The carriers will play an indirect role for communications about the enhanced premium tax credits. We did reach out to them about their messaging. The Connecticut entities are informing customers that they can contact Access Health CT with any questions. And Anthem informed us that they are sending a message in their renewal letters that they also send out to customers. And they also have information on their public website as well. Next slide, please. Are there required system rebuilds? Yes, system changes to support the expiration of the enhanced subsidies are required, as well as some of the other federal changes. They will be implemented in a planned update to the system on October 10th. The first change is implementing the ceiling for who is eligible for advanced premium tax credits if the enhanced subsidies expired. We've been referring to that threshold, the over 400% of the federal poverty level, who will unfortunately not be eligible for financial assistance if they are not extended. The second system change would reflect the reduction in subsidies for customers who are still eligible, that population we've been talking about between 100 and 400% of the federal poverty level. Their subsidies will be smaller, and there is a system change that updates the values for the formula to calculate the tax credit amounts. If a decision is made by Congress to extend the enhanced subsidies, there will be additional system and operational changes required. Access Health CT is prepared to make these changes if and when the enhanced subsidies are extended. We will continue to collaborate with the carriers to adjust our plans to ensure that Connecticut residents have access to all the financial help that's available to them. Next slide, please. Are there online subsidy calculators available to model impacts? Yes, the Access Health CT website always has a calculator available referred to as anonymous browsing. A consumer can go in and put in anonymous information about household size, the county that they live in, because that is a rating factor in Connecticut for premium, and also the annual income for the household. The last week of October is our window shopping period when the 2026 rate information and subsidy amount information will be available in the calculator as well. So consumers can go in there, brokers, and do some modeling to see what the difference will be, in addition to receiving the letters that they get. As I mentioned, all Access Health CT customers will receive their projection letter in the mail in October, detailing all of those costs and giving them their personalized estimate for their plan for 2026. Next slide, please. Our navigators being trained, we've kind of been talking about this. Yes, navigators as well as brokers, certified application counselors, community partners, and call center representatives are always trained and certified before the open enrollment period, including any relevant information for that year. And for this year, obviously, we will be providing the additional information on these federal changes, and also additional training is being provided in person during our annual community conference, which will be held next week. Excuse me. Digitally, sorry, someone's got their volume on. Digitally via webinars and flash alerts through our Access Health CT training team, and also ongoing messaging updates will be going through the broker CAC and community partner newsletters. And the navigators also receive the community partner newsletter as well. So we have many channels to communicate this information. Next slide, please. Is there a role for brokers? As we've been talking about, yes, there's a vitally important role. Brokers have always been an essential part of our strategy, helping residents choose the best plan for them, and it'll be more important than ever for 2026. Next slide, please. Is there a role for the carriers? We always collaborate with the carriers, and we will continue to do so, and we really value their input, especially during these challenging times. Next slide, please. If the state steps in to cover subsidies, how will Access Health CT provide oversight? Claudio and Zanny talked about this a little bit, looking at what some other states are doing as well. Access Health CT would work to update our system requirements if the state does go down this path, to reflect any changes, and would communicate to the customers as quickly as possible using our existing electronic communication with the carriers. And we continue to be open to doing what needs to be done to support Connecticut residents, as we've always done. Next slide, please. I think that might be the last one. Thank you. I will pause for questions. Thank you very much.
Thank you very much, Susan. And I really appreciate you answering all the questions that we said ahead of time. It streamlines it for us and everyone in the room. That was great. I think my biggest concern is going to be the communication and wait times and things. And I have found that people aren't necessarily being proactive about their insurance. So what I fear is that January 1st comes around and then there's going to be a lot of issues, a lot of calls. So it sounds like you guys are ramping up for that and doing the best you can to communicate. I heard you said you were doing texting, letters, and emails, so and postcards. So very hopeful that all of those things are available, and we don't have people falling through the cracks. With that, we have a question from Senator Lesser.
Yes, thank you, Madam Chair, and thank you, Susan, for that thorough presentation. Just a question about that last point that you made about what would happen if the states decided to step up. First of all, I think in order to maintain effort, I think we'd be losing about $353 million in 2025 if we were to cover the expiring income-based subsidies and also the lawfully present folks, but that would be with $25, so we'd have to make it a 20% adjustment north. If that is that correct, just to account for the higher insurance rates in 2026? Is that right?
I mean, the formula is a little not tricky, but because the tax credits are calculated based on the premium, as premiums rise, tax credits rise as well with them. So I don't know that it's exactly 20%, but we can try to calculate. We just recently got the approved rates for 2026. And as I've said, the numbers that we've been providing to various parties in the state have been based on 2025, but we will be making updates for 2026. But yes, it would be higher.
So you had just a quick thing, just sort of about what would the communication strategy be in the event that the state were to try to step forward and make up the shortfall. But is there a procedure in place for both the income-based subsidies and for the lawfully present, is there a mechanism for Access Health to contract with the carriers to provide the subsidies if we chose to go down that route? And how quickly could that be stood up?
I mean, currently Access Health does not do premium aggregation, so we don't play a role in the financial transactions. The federal subsidies go directly from Treasury to the carriers, and then consumers pay the carriers. And for the Covered Connecticut program, that is done through the state now. It is done through DSS. So I think there'd be opportunity to maybe piggyback on that. Access Health currently does not have other than transmitting the amounts and the information between the parties.
So you have no way of doing that.
We currently don't, but we obviously could, if the state determined the eligibility criteria, we would make the change to the system and would communicate to the carriers and to the state entity that may be, handling the financial aspect.
But let's say tomorrow we have a large budget reserve fund. Let's say tomorrow we made a decision that we thought that the feds were not going to come to our rescue, and that we were going to make $400 million, just take 350, make an adjustment, give or take, to try to keep the tax credits going forward for the lawfully present and for the income based. We hand you $400 million. What would you do? What would you need to do to be ready for open enrollment?
I mean, like I said, because we don't currently have any role in that, we would obviously have to have costs to build the infrastructure, to provide that level of support.
So do you think
But there is an existing structure that the state has for the Covered Connecticut program for the state portion of that is already in place as well.
Right, but Covered Connecticut's the obvious model where we don't provide an individual. I mean, we could do this on an individual basis, the way California does with state-based subsidies, where you have a state-based tax credit. That seems more complicated, but with Covered Connecticut, we do have contracts with the carriers to provide service, and so, obviously there have to be some agency that would interface with the carriers. It doesn't sound like Access Health is stepping up and saying that we want to be that agency, or am I?
I mean, we don't have anything in place, so I would have to talk to James Michelle, our CEO. We would have to put all the infrastructure in place, to be able to do that. I'm not saying we're not. I'm just saying that we would have to put that in place. It doesn't currently exist.
Okay. And just on the other question about following up on Representative Wood's question about the public facing, people are going to start freaking out when they realize, one, that they may be losing Medicaid, and certainly folks who are looking at the new premiums are going to be concerned and looking for affordable options. And so it would make sense if call volumes went up. What are your plans what's the size of your call center currently? And do you have plans to grow it? Do you need to grow it to handle the expected call volume?
We use a vendor to provide our call center services, and they have capability from all of their different resources to expand the number, but we did ask them to increase the number of call center reps. So they are already putting that in place. But if the call center volume really starts to spike, they do have capability to perhaps try to draw from other areas to fill that volume. And hopefully also, as I mentioned, the enhancements to our IVR system can also help in that regard as well. And we do have live chat available through the call center as well. So there are many different avenues for consumers, to speak to someone, so to speak.
And do you need additional resources to help with that?
No, I mean, the call center is, we have our cost structure in place. We share the call center services with the Department of Social Services. So, I mean, we would have to see, but probably, we'd probably be okay, but I would have to check.
If you don't mind checking, I'm interested
Sure.
in that, in part because I'm working with DSS on their other call centers where they do need to make major investments. And so if we make investments on one DSS funded call center, it would make sense if we made DS investments all around, but if we don't need to, we don't need to.
I can check on that and get back
Okay.
to you, Senator.
Thank you very much. Thank you, Madam Chair.
Any other questions? Representative Nuccio.
Thank you, Madam Chair. I have a follow-up question to Senator Lesser and just one other question. In looking at your presentation, it's getting a little confused in the numbers. At one point, you said there was 158,000 currently enrolled on Access Health, of which 50,000 of those were covered CT. But then there was another slide that said it was 142, but I think maybe that 142,000 were people who were getting financial assistance. Can you just clarify the numbers that are on Access Health, how much of them are covered CT? And if you have the number, how many of the enrolled are currently receiving financial assistance?
Sure, thank you. There are a lot of numbers. A lot of
I'm a numbers
people-
person, so I
No,
get it.
yes, yes. No, I appreciate that. And a lot of people today, talking about all these different impacted populations. So currently we do have the exact number as of today was 158,343 people enrolled in coverage, qualified health plan coverage through Access Health CT. Of that number, 143,031 are receiving financial assistance, which is 90% of the population. And further breakdown of that population receiving financial assistance, 51,714 people are enrolled in the Covered Connecticut program, which is, a subset of those other numbers. It's not separate.
Okay, so that makes more sense. Then you had said about 28,000 of those people enrolled on Access were over 400% FPL.
Correct.
Okay, and
So
then
they would
they would lose
lose.
all subsidies. So take away the 51 for covered CT, which we know are safe. That gets us down to 107-ish. Take out the 28, we're looking at like 70 something thousand that fall below the 400. And they are still going to receive some subsidies, just not the extended subsidy. Do you have a breakdown of and you don't have to get this to me now, but do you have a breakdown of what that looks like financially? What subsidies will they continue to receive? What are they losing? And then in a follow-up to the question that Senator Lesser asked regarding the 354 million, can you break that down by that same sort of population? Do we expect the largest impact for those subsidies to be coming from the people who are mainly over the 400% FPL? I'd like to see how that breaks down. Honestly, 354 million, I don't think there's a way for the state to fully subsidize this. There's no way. But I would like to understand the financial impact broken down by the FPL and where the biggest moving pieces are. I'm assured you don't have that right now, but if you do, that'd be wonderful. If you don't, if you could get that to the committee, I'd appreciate it.
Thank you. No, I do have some information I can share with you now, and I can
Okay.
also send to you as well. And I'm trying to remember now, the first question you were asking, so the population, the difference between what they would get if the enhanced subsidies aren't extended and what they get. So the original ACAs are based on a contribution scale, if you will. So under the enhanced subsidies at the lowest income, it went down to it started at 0% contribution for consumers with income below 150% of the federal poverty level. And it went up in increments it goes up in increments accordingly, in income thresholds. So where it now currently starts at 0 for those of the lowest income, under the original ACA, I think it's 2%, or don't quote me, a little over 2%. So, and then it goes up accordingly. Under the enhanced premium tax credit structure, the cap that a consumer has to contribute is 8.5% of income towards the lowest silver, but 8.5% of household income. So there are consumers, that's why all of these consumers with income over 400% of the federal poverty level have fortunately been eligible for premium subsidies since 2021. And we all know 400% is not high income. That's still moderate income. You know, for a family of, I just happen to have this number in my head, for a family of 5, the federal poverty level, 400% right now, I think is a little over 150,000 per year for a family of 5. So people with income above 400% going up, as long as it wasn't more than 8.5% of their household income, have been eligible for premium subsidies. And there are enrollees through the exchange who go up to age 65. So, you know, we do have a number of people in their 50s and 60s who maybe have, you know, are consulting or in different employment situations and aren't eligible or don't have employer coverage available. So the exchange has been a really vital opportunity for them to have coverage, and under this structure to really have some help affording their coverage, because premiums do go up depending on age. Connecticut uses 2 rating factors, county and age. So it does go up a lot for those consumers in their 50s and 60s. So I can give you some numbers if you want, just large numbers on this impact that go into that 353 million number. So the population who would completely lose eligibility for subsidy with income below 100% in 2026, that is roughly $60 million for that group. That is the whole subsidy that they're receiving now. Excuse me, the 5,300 people. For the group between 100 and 200% of the federal poverty level, the difference between the enhanced subsidy amounts and the ACA, the original ACA subsidy amounts, the delta is about $54 million for that group per year. These are annual numbers. For consumers between 200 and 300% of the federal poverty level, that delta is about $47 million. And I will send all this to you so you don't have to remember all these numbers exactly. And then for those between 300 and 400% of the federal poverty level, the delta is about $23 million. And then, as we mentioned, the largest number really is for this 28,000 above, with income above 400% of the federal poverty level. And that is total subsidy, and that comes out to over $168 million. So that is kind of the breakdown of those numbers.
Well, I congratulate you for having that for me ahead of time. That is perfect. The people who are losing it, it's the 141 DACA and the legal immigrants, correct? That's total about.
Yes, the 144 have already, unfortunately, their coverage ended yesterday. Not all of those, you know, DACA recipients necessarily were in that under 100%, you know, of FPL. You know, I don't have the exact breakdown. I can get it for you if you want. For that 144
No, I
people
don't
where they
need to
fell
get to that
FPL, but yeah.
minutia. Yeah,
So
so
they
60 million
unfortunately,
estimates for
right,
them. And then, okay, so
right.
this is the breakdown that I needed to hear. I
Yeah,
agree.
so the 60 million is really that population that we've been talking about today, the 5,300 folks that will lose their eligibility for subsidy in 2026 under HR 1.
Okay, perfect. Thank you so much. I appreciate it.
Thank you.
Representative Pavlik Tomato.
Thank you. And thank you for the presentation and for meeting with us yesterday, a couple of us to go over some of this information. It was very helpful. My question is, and I know we discussed yesterday that the enhanced subsidies were COVID, and knowing that a lot of funding via COVID was temporary. We're going back basically to pre-COVID numbers, right? With some enhancements, not with this, not with the enhanced credits here. So is anything being done that you know of at the federal level to really address what probably would exist and still exist if we didn't have COVID? And that's the fact that, and I remember after, before, and especially before COVID, just how a lot of constituents would come in, and when I told them to go on Access Health, it was still extremely unaffordable. So do you know if there's any look at the system itself, and or anybody at the federal level trying to address the fact that this program just in and of itself is unaffordable?
I mean, I can't speak for the federal government, but and the insurance department is here today as well. We know premiums are expensive. Connecticut is a high cost state. We have very high premiums, but that is really due to, high healthcare costs in the state. Under the ACA, 80 cents of every dollar has to be used by the carriers to pay claims. They could only have 20% for administration and profit, and they run higher than that. They spend more than 80% on claims. So it is, a lot of cost in there for comprehensive coverage. Something that we do, Access Health CT, is to try to make a variety of coverage options available for consumers at the different levels. And I mentioned earlier, standard plans. Those are plans where the Access Health CT board dictates the plan design, the benefit design for those plans that we require all the carriers to offer, so it is uniform across carriers. The standard silver, we have two different bronze, HSA and non-HSA, and the gold as well. And we really strive to have as much first dollar coverage available as possible. So that is coverage before the deductible. So people feel like they are getting value for their plan, to meet their healthcare needs. So our plans across the spectrum, even the bronze plans, do provide that coverage before the deductible in many different areas.
Thank you so much. I appreciate that.
Thank you.
Okay, I don't see any, do you have a question?
No.
Okay. All right, great. Thank you. Thank you very much. We appreciate the always being available for us, and I'm sure we will continue to have dialogue and discussion. So appreciate you being here, Susan.
Thank you very much.
Next, we have Commissioner Andrew Mays from the Connecticut Insurance Department.
Senator Cabrera, Representative Wood, Representative Pavlik D'Amato, and distinguished members of the Insurance and Real Estate Committee. I want to start off by thanking you for the opportunity to participate in this critical discussion at what is a critical time in our state and in our nation. This is our first day of the federal government shutdown. We know there are uncertainties, and I'm honored to join my fellow executive branch agencies and members of the healthcare and insurance community. I know consumers are looking to all of us for answers and solutions amid so much uncertainty. And the one thing I know to be certain is that we will continue to work together to protect Connecticut consumers. That will remain our overriding commitment. I know because this is what we've done, both through the agencies and working with the legislature. And I want to thank you for all that. And I look forward to working together in the future as we've done with vaccines and the federal changes, for instance. Let me start off by taking a look at the existing conditions in the fully insured individual market. Now, the fully insured individual market continues to contract. Right now, the carriers are Anthem, Connecticut and its subsidiaries, and United Healthcare and its subsidiaries. The number of insurers offering those plans continues to shrink. Now, to put it in context, in 2016, so a mere 10 years ago, there were 21 rate filings from 13 carriers that covered 340,000 people. For the 2026 plan year, there were only 8 filings from 7 carriers, and that covered 224,000 people. This year was a difficult one, even more difficult than normal, because not only are the high costs, and we've heard about the high cost of healthcare, we've heard about the increased utilization, and those are reflected in the premiums. But this year, we also had to deal with the uncertainty of the subsidies and the other ACA protections that we've all been talking about. And just as a reminder here, Connecticut Insurance Department regulates individual and small group fully insured health plans offered on and off the state exchange Access Health Connecticut. And that represents about 25% of the insurance or the insured population in Connecticut. We do not don't regulate the state plan, for instance. We don't regulate self-funded plans that fall under the authority of the U.S. Department of Labor under ERISA. That's another 75% of the insured population, insured working population. And we do not regulate Medicare or Medicaid. That is a federal issue. So how do we attract, I see we've already moved to the next slide. How do we attract more carriers? Let's identify some of the challenges first. And we've heard Connecticut is a high cost state. We've got a small market and a small state. It is not a very profitable market. One of the things that we know is competition is attracted to a profitable market. This is not a profitable market. In recent rate filings, the filings we approved a few weeks ago, we limited profits to less than 1%. As regulators, we have to walk that fine line, that prudent balance. We have to protect consumers from rates that are not excessive, inadequate, or unfairly discriminatory. But we also have to closely monitor the carriers to ensure that a healthy, solvent industry is available to provide that range of products and where insurers have the funds to pay all their claims. Because if an insurer becomes insolvent and cannot pay its claims, all policyholders suffer and the market as a whole suffers. I would love to see more carriers in the market. More carriers contribute, as I said, to a healthy, competitive market that can affect pricing, improve service, and support more innovative insurance products, more choice for consumers. And consumer protection remains our North Star. We actively support industry innovations and we encourage beneficial technological advances for better health outcomes. One of the things is healthier risk pools, and this is part of how insurance has changed dramatically over the past 2 or 3 decades. Insurance used to be all about spreading risk. So the overall risk is there, and we're trying to make sure that that finding coverage for that risk is as affordable for each participant as possible by spreading that risk. But insurance has more and more also become about risk mitigation, reducing that level of risk, which reduces the cost. I mean, I've got my watch. I won't tell you which one because I'm not going to promote any brand, but that's, wearables. That's one way of measuring your health. That's one thing insurance companies are doing, working with consumers. For those of us on the state health plan, we have health enhancement programs that help to keep us healthy, which is, great outcome, at least for me in and of itself, but also helps to reduce the cost in general. So we are going to continue to support this. We are going to continue to work with AI and SureText. We are going to continue to ensure that the rapid advances in technology will help to benefit consumers as we move along. Because, industry needs clarity. Consumers, we will do whatever we can to provide them with lower prices. And I think we all agree that the best outcome is if we're all as healthy as possible. And AI and technology will do that. This is AI, for instance, is being used by a number of health carriers right now. We did a recent NAIC, National Association of Insurance Commissioners survey of about 100 health insurance carriers, and we found that 84% are currently using AI and machine learning in some capacity, and that's across a range of healthcare product lines, individual major medical, group major medical, student health plans. We're looking and companies are looking at the use of these tools for utilization management practices, disease management program, and fraud detection. All in order to reduce the overall cost to the consumer and to ensure that health insurance, which is for many of us the way we pay for health care, as affordable as possible. Now, you take a look at Connecticut. How do we compare as a regulator to other states? And one of the reasons we have state insurance regulation, going back to McCarran-Ferguson, is that state insurance regulatory environments are uniquely shaped by the diverse needs, the interests, the risks, and the legislative frameworks of each individual state. But what does unite us is that shared commitment to protecting consumers, fair pricing, transparency, safeguarding policyholder rights. Every state regulator operates with the consumer's best interest at heart. And we work together, nationally aligned, in order that we can see, part of this is information sharing. We need to know, we've heard an awful lot here about what's going on in some other states. We need to know that certainly we in Connecticut are able to hear what's going on throughout this country and use it for the benefit of our consumers. Connecticut yesterday we held our Ensuring the Future conference at the Hartford Marriott, which was really very well attended. And as a number of the speakers said and agreed, we are the insurance capital of the known universe. I kept pushing that line because we are. We have a solid, respected regulatory environment. It is part of our DNA. And because of that, we have the privilege and the obligation to regulate some of the largest carriers in the nation. We will continue to fight to retain that reputation nationally and internationally. And I think it's something that we all in this great state can be proud of. Our in-house actuaries, the ones that are actually looking at the rates, they know the Connecticut market well. The experience, the trends, the risks, they are all career credential professionals. And we have worked with some of the same carrier actuaries over the years. Communication is there. Communication is vital. And I think the mutual respect is there that continues and contributes to that trust in the regulatory environment. Just to give you an idea of how good this department is, over the last slightly over a decade, 3 of our staff members have been recognized with the highest national award an insurance regulator can receive, and that is from their peers, the Dedeen Award. Kathy Belfi received it for financial regulation. Former Life and Health Director Paul Lombardo received it, and current Property and Casualty Director George Bradner received it. And we've, worked to recover millions of dollars for consumers. And through fiscal 2024, we delivered more than $100 million through industry assessments to the insurance fund that supports things like childhood immunization program, the Office of the Healthcare Advocate, the Office of Health Strategy. Insurance is vital to this economy. Health insurance certainly is vital to us as consumers. And we will continue to do our best, even in this incredibly turbulent environment, to react as quickly as possible to ensure that consumers are as informed and as protected as possible. So with that, let's move on to HR 1. And I will say we're going to continue to monitor the emerging situations closely, both in the state and in Congress. The shutdown, at least in my mind, and I speak for myself here, it's done a major disservice to consumers, but in particular to those individuals and families who need the federal subsidies in order to afford a health exchange plan. The NAIC is a national organization of insurance, National Association of Insurance Commissioners. We've got 56 members. The 50 states, the District of Columbia, the 5 territories, very different geographies, very different demographics, very different politics. Yet all of us have been actively lobbying against many of the provisions in HR 1, including the expiration of the enhanced premium tax credit, the annual eligibility verification, and the renewal of cost-sharing reduction process. We also have significant concerns, of course, with the CMS's new marketplace integrity and affordability rule, which will shorten the open enrollment period starting in plan year 2027. A shorter enrollment period would probably lead to fewer people enrolling, and that period would be shortened for a month. State-based marketplaces will have a little more flexibility than federal marketplaces, but still face restrictions. We know this will limit access. We know this will reduce enrollment, and we are grateful that currently several of the provisions are under a court injunction and cannot be enforced. Nonetheless, this adds up to more uncertainty. And one of the issues is we are keenly aware that uncertainty can open the door to scams or to non-insurance products that will not protect consumers. That's why we need to do everything to keep consumers informed. We've seen many of the plans over the years, discount plans, risk-sharing plans, healthcare sharing ministries. Some of them do the job, but they are not insurance products. They are not regulated as insurance products are. Consumers are not protected doing that. The only thing that they may have to offer is a lower cost. And we need to make sure that consumers understand that there is an opportunity cost to that it may be, and we have seen this, that you sign up with a plan that looks good, but when it comes time to get the coverage you need, it's not there. That's part of what we're afraid of as we look at the uncertainty with the Affordable Care Act and what will happen. You take a look at the Affordable Care Act, you take a look at the changes that or the projected changes, let's just say nothing changes between now and then, but between now and the end of the year, between now and open enrollment. The CBO, the Congressional Budget Office, estimated that more than 4 million people would lose coverage in the first year. That is a significant cost that will be imposed on society as a whole. Simply because people lose coverage will not mean that they don't have to have health care. What it means is they will go to the emergency room. What it means is there will be an increase in uncompensated care. What it means is that the commercial market, so the people who are paying these premiums are going to have to pay more. What it means is that the people will be sicker, so the costs of treating people that don't have coverage are going to increase. And certainly, as we've seen, for rural hospitals, it could be a life or death. It could be existential for these hospitals. And that's a life or death issue for so many of our consumers. So we keep working. Another related concern for me is what happens even if we get the subsidies restored sometime between now and the end of open enrollment. What's going to happen to those people who take a look? They've had the plans, they know what they paid last year, and they look and they get sticker shock because suddenly they realize the subsidies are gone and they're going to be paying so much more. Even if the subsidies are restored somewhere during open enrollment, will those people go back? Will those people decide that, all right, let me give it another shot? Or will the sticker shock be enough to drive them away completely? And we've seen in other markets and prior to the ACA times, what that could mean is that we end up with adverse selection. Only the people who most need health insurance, in other words, the people most likely to use it, are the ones that are going to go and purchase it. They're going to be higher cost. So again, what happens? That cost gets distributed to everybody else. Because according to the CBO, it is like, and the Kaiser Family Foundation, others have looked on it, it is likely that the people who will drop coverage are what we call the young invincibles, the ones that we need in the market in order to balance the cost. Clearly, there is much that we have to do, but the one thing I will guarantee you is that we will continue to work as we have done with Access Health, for instance, with OPM, with our insurance industry colleagues, and certainly with the legislature in order to do the best we can for consumers in these difficult times. Thank you for having me.
Great. Thank you very much for being here. I want to talk about slide 2, which shows the fully insured market and the amount of carriers that were in the space. I mean, to me, that's like a crisis looking at that slide, and seeing how little carriers we have doing business in the state. I wanted to ask you, when carriers leave, do you do like an exit interview or a discussion with them of what factors cause them to pull out of the market?
We discuss any carrier that comes to us that says they want to pull out of the market. And there have been a number, especially in the small group market over the past few years. We discuss with them the why. This is, again, part of this is that it's a small market. And just in terms of the number of consumers, it is not a profitable market. It is not a market, and I know this is hard for many people to believe, where the insurance companies actually have the upper hand. You know, they can't go in and say, we're only going to pay you this much, because we do have requirements that the networks be adequate. And in many cases, that has meant that, you know, the insurance companies have to figure out a way to get all the providers or provider groups, or as many of them as possible, within their the networks that they offer. It's, yeah, there are mandates. It is a difficult market to be in. It is a great market to get healthcare in. We've got some of the best healthcare providers in the world here, but that there's an associated cost, and it's not someplace where carriers are going to make lots of money. And I will, you know, the one thing I could say, usually I couldn't say this, but I know it was brought out, I think, in the hearings either this year or last year on rates. You know, many of these carriers, even certainly the remaining carriers, are not ones that are focused solely on the Connecticut market. We had one carrier that was primarily focused on the Connecticut market. And yeah, if you just do a Google search of what they said about how much they lost last year, that will tell you what kind of market this is, and, you know, how profitable or unprofitable this market has been.
I would argue that when we have 353,000 customers in the fully insured market, it's a much more profitable market. And when we have 200,000, it is not as much of a profitable market. So this is the fully insured market that all of us in this room regulate. You know, our fingerprints are all over why carriers are leaving. I will just highlight 2 things that happened recently. One, we passed a bill that additionally dings health carriers if they don't comply with the benchmark. We don't have any other industry that is held to that standard. So we have sent a message to the entire country that if you come here and don't comply with the benchmark, we're going to come after your rates. So I don't see how we're attracting anyone additionally to the markets. I will also say that the assessments, which are now over $110 million to pay for state services, is ridiculously high. We did this, you know, committee did a working group, and we dove into the assessments and put forward recommendations to rein in some of that. And, you know, we weren't able to successfully push those forward, but we did that working with the industry. We've also offered things like a premium tax reduction. You know, we're trying. Sometimes we feel like we're the sole entity trying to attract more businesses here to perform in this space, but it really has been an uphill battle. I will reiterate to everyone in the room that during the rate review, you did say that the profits was capped to not 1%, but 0.95% this year. I think that's something that, you know, we all need to just think about as we're trying to deal within this space. But I'm really glad you hit on the positives, because Connecticut should be a place where you can do business here successfully, because we were just ranked like one of the healthiest states in the country. So you were talking about, you know, adverse selection. Well, if we have this healthy population, why aren't we promoting that and, you know, reaching out to carriers with like, hey, you know, look at our great health system, you know, look at the providers we have. It's not perfect. I know, you know, we all have our own issues, but we are recognized for a quality care system. We're recognized as a healthy state and a, you know, nice place to live. I think we should be turning that story around and promoting that this is a place to do business. Lastly, you did talk about the fraud. So I think that's something I would just like to hear how you're planning on managing that. So say some of these 5,400 people that are potentially going to get dropped, fingers crossed we find a solution for that, but they start getting calls from groups that are not really providing health insurance, but are selling them, something that's fraudulent. They sign up for that. They call the insurance department and say, I just went to the doctor. I bought a plan. I'm not being covered. How are you reacting to that?
My hope is that we would be more proactive than reactive by pushing out information. Part of what we're doing, and this is, one of those phrases that you think of, so you're the consumer. Just yesterday, we announced, and this is on the property casualty side, that if consumers go to our website, there will be a link on the website that they can put in their address. And we've signed a contract with the First Street Foundation. They're a mapping analysis predictive modeling company. And the consumer, free of charge, if you're thinking of buying a house or if you've got a house, you're going to look on it, you put your address in, and it spits out a report telling you what your risks are. So you're able to address those. I mean, it's one, if you have a house, you'll know what to do. You'll be able to do something positive. If you're thinking of buying a house, you will know what to do. You don't have to rely on static risk maps. We are trying to do the same thing with health insurance. We've got a great, we've got a whole website, essentially a mini website devoted to explaining to consumers the market, what to do and how to do it. We've got our people that are there within consumer affairs that are doing more outreach, which is, before COVID, we used to do a significant amount of outreach. After COVID, it got a little more difficult, but we're back. We're out there trying to reach people all through the state, whether it's at the libraries or the Kiwanis Club meeting. I'm a Rotarian, so I'm going to say something nice about Kiwanis. But with legislators, we want to, with town halls, we want to be out there getting that information out, and then that's combined with our, the usual stuff, the social media presence, the consumer advisories. We need, and we know this is going to be especially important as we move forward, to convey to consumers that cost is not necessarily what you should look at. We know the costs are high. I mean, that's something that you simply can't ignore. You can't tell a consumer, hey, this is, it's going to cost you so much less. You're not. I mean, you're going to get what you pay for in so many ways. We want to make sure consumers understand what they're paying for. If you know, as a consumer, that you could get a fully insured plan and it will cover this and it will be there for you, and if you decide that that's not what you want to save some money up front by going to, healthcare sharing ministry, that is a choice that you will make. But we, as a department, need to make sure that that is a fully informed choice. And that's part of what we're doing. And then on the flip side, on the fraud side, we work both, in our market conduct division, and we work nationally with the NEIC because a significant amount of the fraud that we've seen involved Medicare Advantage plans. We work to ensure that the bad actors are targeted and to do all we can to stand between the consumers and those bad actors.
Yes, that's wonderful. Thank you so much for those questions. I love the idea that you'd be available to do forums, and we'll set one up for my district.
Absolutely. And, I've been saying that because, as I'm sure we've known, the staffing levels of the state, and we fully restaffed. There is nothing. We've got a great team. They love to be out there. If you want to, if there is anyone who wants us, reach out. We'll be there.
Thank you for that. Senator Cabrera.
Thank you, Representative Wood. Commissioner, thank you for being here, and also thank you for being so open. Your staff has always been incredibly easy to work with and available to us when we're trying to make sense of some of this stuff that we're trying to learn here. But my question is, you referenced the CBO report, the 4 million folks who are estimated to lose health insurance as a result of what's happening in Washington DC. I was wondering if you had any sense of what Connecticut's piece of that would be, number one. And number two, and I'm not asking you to recommend policy here, but what are some of the things off the top of your head that Connecticut should be doing to prepare for that?
You know, I would defer to Access Health or the Office of Health Strategy on the numbers in Connecticut. They've got better numbers on that. They've got ongoing numbers, better numbers than I do. They would be able to share that information with you. And I think Access Health did provide some information as to how many people they expect to be dropped from the rolls. You know, part of what we have to do is to take a look on this. Essentially, what we did, we take a look back at what happened during COVID. During COVID, we found, certainly, and I'm referring to Access Health here, that there were significant populations that did not trust either the insurance companies or the government, significant populations that were able to get low or no cost health insurance that weren't taking it. So what happened? There was a broker academy set up where people from communities that were underserved were being trained to go into those communities and to provide that information. And we've seen, if you take a look at what happened, you know, we've seen that there was a significant impact from that. You look at Covered Connecticut, and the numbers, I think the numbers may have been on there. The numbers of people covered in the fully insured plans, that's a downward trend. But you saw when Covered Connecticut kicked in, it went up. It's part of that outreach, part of trying to figure out new and innovative solutions. We know the problems. Problems are there, and certainly, especially at this point, we don't see those problems going away anytime soon. But we need to figure out new ways around them. We need to figure out how to reach more people, and we need to figure out ways to get people the access, the ability to access insurance that they need.
Thank you for that answer. One of the things I struggle with and continue to struggle with is oftentimes the approach is there's different markets, but you know, to your earlier point on top of your opening remarks about how what happens at the national level or in any given market has an impact on all of us. So you reference people showing up to emergency rooms to receive care, which will have an impact on all of our premiums. And we don't have to go too into it right now. I mean, we can have another conversation offline, but that's one of the things I'm trying to wrap my head around is like how are what's happening going to impact not just the individual market, but all healthcare plans in a variety of ways.
Well, if you take a look at the healthcare market as it currently exists, let's look, there are two huge payers that, and I'm looking at the payment side here. There's a government payer, so that's Medicare and Medicaid. And then on the other side, you have the commercial payers, which is everybody else. Government payers have essentially fixed costs. Okay, you can say this is what, you know, this is what you're going to pay under Medicare or Medicaid, and the hospital has to take it or leave it. One of the things we heard in that rate hearing that we held recently, and we heard this from a variety of players in the market, not just the insurance companies, but we also heard it, I think, probably for the first time from a number of providers. Those payments may not necessarily cover their costs. So in a sense, those costs are being subsidized by the rest of us. You know, how do we address that going forward? And, you know, we do what we can. I'm not sure how much we can do aside from working to reduce overall cost that is going to make a significant impact in the cross subsidization that commercial payers currently, by commercial payers, I mean consumers, because those are the plans that whether it's Access Health or any of the others, all the fully insured plans that we currently have to undertake.
Thank you for that answer. I appreciate it. I look forward to more dialogue with you and your team as we continue to wrap our heads around this issue. So thank you so much.
Absolutely. And we look, you know, again, we've had a number of conversations on this, and part of the way, you know, part of what I think we need to do is that innovation. We've got to find new ways forward. We've seen ideas that have come before this committee that this committee has supported that may not necessarily have gone on to fruition, but we would love to continue working with you.
I look forward to that conversation. Thank you.
Representative Nuccio.
Thank you, Madam Chair. And Good afternoon, Commissioner. We've hit afternoon finally. I have a quick couple of questions for you in regard to something Representative Woods said. And through the last rate reviews, I know that profit was limited to, like you said, under 1% or 0.95%, as Representative Woods said. And the law that did pass, as she mentioned again, about insurance companies and their rates and tying it to the benchmark. There's been a really big push for what I like to call a keyword with no substance behind it, which is basically pushing for the rate reviews to have an affordability push or an affordability factor. With that, what's been talked about is whether or not people can afford their insurance coverage. And having that be some sort of factor in the rate review process. And I know people in your department have also talked about the affordability push. You had mentioned in your display that there are 8 carriers now. The pool has gotten smaller across the board. Rep Wood asked about basically, we're healthy, but how come we can't get people in this market? And, link that to the maximum 0.95% profitability. I'm not aware of any other industry that I know of that has a profitability maximum. Like that's seems to be pretty exclusive to the insurance industry. But how do you see that playing out? If people keep pushing for this quote unquote undefined affordability, and we layer that on top of the rate reviews with already an under 1% ability for profit, how do you see that playing out in the market? Do you think we're going to get more carriers that want to come here when they have to figure in what some affordability for any one of the members on the plan are? And is that going to push into their 0.95% profit margin?
What we're trying to do, and certainly what I think the state has been trying to accomplish with the affordability question, with a benchmark, is to take a look at the underlying cost of care. What we want is to give the carriers the ability to say, this is what the cost of care should be. Why is it more than that? These are questions that we then, as regulators, would you as legislators be able to ask? We need to know that. We need to know that, there is not waste and fraud or simply too many providers that are driving up the cost of care. And when I say too many providers, I mean that in an economic sense, where you drive up the cost by driving up the services. We need to make sure that there is not overutilization of services. We need to make sure, for instance, that primary care providers, who are usually lower cost providers, and understand their patients better than pretty much any specialist, that those primary care providers are properly compensated, because we know that will reduce costs. The way I look at affordability it certainly is not going to result in rates that are either excessive, unfairly discriminatory, or inadequate. That would not fit with the actuarial guidelines, that would not fit with the requirements that we are under. But what we need to do is to give everyone involved, whether it's an insurance carrier or a hospital or a doctor, we need to ensure that everyone has the ability to look at the costs that are currently in the system, justify those costs, figure out which costs we can address, which costs need to be there, and make sure that the cost of the underlying care, because when you get right down to it, health insurance is really just a payment mechanism. We want to make sure that the cost of the underlying care is as low as possible. That's really what we're hoping to get to. We're hoping to provide tools to everybody involved to ensure that consumers can continue to afford this wonderful healthcare system that we have.
So you mentioned a few things there that I think I'd like to kind of clarify. First of all, whether or not affordability, you're saying, whether rates are excessive, unfair, or inadequate. I believe that's already the process that we have, right? That has nothing at all to do with changing or adding an affordability factor. The Department of Insurance is already reviewing rates for excessive, unfair, inadequate, and they're the ones who determine that insurance companies can only make a 0.95% profit. So I would say that piece is already there and established. In terms of cost of care, you mentioned some very key things I wrote down: provider cost of care, compensating providers, and making sure insurance policies reflect affordability. I'm wondering if you know something that I don't know when it comes to the power an insurance company has to negotiate against a conglomeration like Hartford Healthcare, and how an insurance company can say to them, you're not meeting the pet cost benchmark, so we're not going to increase your rates. Your rates are going to stay flat. And what happens subsequently when those healthcare organizations say, okay, we're not going to service your members? And then those members get a subsequent letter in the mail saying, Rockville Hospital is no longer in your network. So when we start to talk about cost of care and affordability, insurance companies do not provide care. So are we going to start at any point now regulating the hospitals and the providers and the actual cost of care? Because as you know, as well as I know, and I'm sure maybe not everybody else knows, that the profit loss ratio, 85 cents of every claim, of every dollar of every cost of an insurance claim has to go to claims. And that is the number one driver of any one rate increase. So I guess I'm kind of struggling with how the Department of Insurance, by installing an affordability factor, again, which has always been very vague and not defined, is going to control the cost of care at the actual point and place of service, and how you would expect an insurance company to be able to regulate, mitigate, and deny network increases.
I'm not going to say that the insurance company is necessarily going to be able to say to one provider or another, whether that's a hospital chain or individual providers, that you are not in our network because of X, Y, or Z. That's for the insurance companies and for the providers to negotiate. What we do want is to give companies a tool, and as I mentioned, healthcare is an imperfect market. We know that. There are significant information asymmetries in the market, and there are other circumstances that in some ways distort the market. One of those, as you alluded to, was network adequacy. Consumers also have their part to play in this. We know that health insurance companies, we know certainly on the state plan, there were narrow networks that were created. And by narrow networks, it meant that you wouldn't be able to go see everybody. It meant that there were limitations on the providers that you could see. But these were providers that were available, that were accessible, that were close to you. Nobody chooses those. And nobody may be a slight exaggeration. But if you look at the numbers that the state network provided, for instance, you will see that there is little incentive for a hospital at this point, and I use a hospital only because it's the top of the food chain on that side of healthcare. Little incentive to negotiate either in or into a narrow network or out of a narrow network, because the consumers are not going to make that choice. That's what we've seen. How do we incentivize consumers to make that choice? That's part of what insurance companies have been working on. Certainly, and I go back to the state plan, that's part of what the state controller's office has been working on. If we are going to provide health care that is affordable, health insurance that is affordable, we need to provide health care that is affordable. Again, absolutely right. Health care is the driver. Health insurance is the payer. We all have the right to health care. We all have the right, and as a society, we have to make sure that providing that health care is not, that the cost of that provision is as reasonable as possible. That's what we're trying to do. And innovation, as I mentioned, is necessary. It may not this one particular item may work, may not work, may work better than others. But we can't sit on the status quo. We know that. because we've seen the same results. We've done all we can, and we haven't seen things changing enough. We need to keep working. We need to be open to ideas that perhaps we may not have been open to a few years ago, but we need to make sure that we are providing every player in this market the opportunity to do what's best for consumers.
Thank you for that. And thank you for delineating the difference between health care and health insurance, because they are very different. And I don't think enough people actually acknowledge that. So thank you for that. I would just say, I'd like to continue this conversation, because I think if we're going to continue to push for affordability, then you have to make sure that the companies you're asking to implement this have the power to implement it, and they don't right now in any way, shape, or form. And I think this is something that we should be crossing over with into the public health arena and other areas where we actually start to look at the cost of health care, which drives the cost of health insurance. So thank you for the information. I appreciate it.
Thank you.
Senator Honig.
Thank you, Madam Chair. and Thank you, Commissioner, for being here. Just a question on your fully insured market overview page. From 2016 to now, pretty significant decrease in the fully insured market, the number of people being covered. Do you know, like, how much of that is going to self-insurance or Medicare and Medicaid or uninsured? Like, is there a sense of that?
I don't have an answer for you right now, and I don't want to mislead you by pretending I do. What I will do is get the answer for you, and we'll get that to you in the next few days. Would that help?
Thank you.
Okay. Yeah. I mean, I think part of what we've seen here, and certainly as you look at the small group market, there comes a point at which people would drop out of the market because it just wasn't working for the employers anymore. And which is why we've been open to doing, again, as I mentioned, doing things that we didn't necessarily do before. Aggregating groups, for instance. It used to be, and we had one plan that was a possibility that did not go through, but we had the discussion, and we said, the one thing we don't like about this is that you're under the Department of Labor, and our issue with that is the same issue that we have with a number of the other plans. It doesn't give us the ability to protect consumers in Connecticut. And they said, we'll let you have that. And we said, fine. But that's the kind of innovation. That's when I say the kind of innovation, that's the kind of thing that we will look at. We are open to listening. We are in, I think the word crisis has been used. I don't think that's unreasonable. I think there is a crisis. And a crisis means that we have to take every opportunity we can to solve it. It means remaining open-minded. It means considering stuff that we normally might not have.
Thank you.
Great. Thank you very much for being here. Appreciate you.
Thank you.
Next up, we have Paul Kidwell from the Connecticut Hospital Association.
Good afternoon. Nice to be with you. I think I have a slide deck. And I certainly don't want to repeat what's been said this morning. There are a couple of items in HR 1 in the ecosystem that I want to talk about that hopefully provide a little more context for the things that we're preparing for related to some potential coverage losses. All right, but I'll get started as we get it up. So just for some sort of general context, and on the heels of Commissioner Mays, I think it's important to know sort of how do hospitals get paid for their services. So if you think about 100% trying to recover your cost, about 36% of our payments come from those commercial carriers. About 22% come from Medicaid in the state. I'm going to split out Medicare Advantage and Medicare fee-for-service. About 21.5% come from Medicare Advantage plans, which do take advantage of the Medicare fee-for-service rates. About 15.5% from fee-for-service. We got a little more than 3% uninsured, and then some others, TRICARE, self-pay, et cetera. So you'll see here that about 60% of payments made to hospitals and health systems in the state are generated from the federal or state governments. And to Commissioner Mays' point, those payments are well below the cost of providing care. And so what you see is hospitals and health systems negotiating as hard as they possibly can with commercial payers to make up the difference. We have to sustain the system for everyone. We can't negotiate with the federal government, and we have very limited ability to negotiate with the state, which I can talk more about later. And so as we think about the payment structure and affordability in the commercial marketplace, I think we need to think about that more holistically, and that government payers have something to do around commercial affordability. Some broader perspective on where hospitals and health systems sit financially. In 2023, net operating margins were negative 0.5%. And between 2022 and 2023, our expenses grew by $1 billion in 1 year. That's labor, that's pharmaceuticals, that's energy, those types of expenses. And you may think, why are you talking to us about the provider tax? HR1 does have a pretty significant impact on provider taxes in the country, and it's important to note that in Connecticut, hospitals between 2012 and 2026 will have paid $10.3 billion in taxes to the state to help fund the Medicaid program in the state of Connecticut. So just for example, this year, hospitals will pay $820 million in taxes. A little over 300 million of that will go to finance hospital Medicaid payments. More than 500 million will go to finance other Medicaid services. So hospitals play a significantly large role in financing the Medicaid program in Connecticut. And just a little more sort of history there. In that same time period, hospitals will have paid 1.7 billion more in taxes than they received back in payments. So we're net negative 1.7 billion. The state is net positive 7.2 billion. So I bring this up because it's important in the totality of payments to know that hospitals play a significant role in financing the state's Medicaid program, which has a significant part in keeping people healthy in the state. If you go to the next slide. I'm going to get my slides here. So if we think about HR1 and some of the things that we're thinking about as related to both coverage and access and then payments. So for a number of years, we were trying to think about how do we maximize federal dollars into the state's Medicaid program? Are there opportunities to do that in ways that we aren't currently doing today? Right now, we don't have Medicaid managed care. So we're in a world where the state can pay providers up to the upper payment limit, which is basically what Medicare would otherwise pay. There was this tool out there called state-directed payments that more than 40 other states use to make payments up to the average commercial rate, so beyond what Medicare could pay. And they usually finance that through the tax program. So we were sort of considering, is there a way that Connecticut could access additional federal dollars to make those payments? HR1 restricts the ability to use state-directed payments. So for us, it forecloses that opportunity. For other states, it starts to bring those payments down. And so for us, we now have to think about, well, what are some of the other ways to help finance the state's Medicaid program? As you've heard earlier today, certainly the eligibility changes in HR1 could have, depending on how we implement them here in the state, an impact on our uncompensated care as individuals who no longer have coverage wait longer to seek care and generally end up in the hospital emergency department. So certainly concerned about those eligibility changes and its impact on individuals. And then I noted that the HR1 changes the way provider taxes can be used in all states, not just Connecticut, to finance state Medicaid programs. It seeks to restrict the ability to use those taxes to finance those programs, which, as I noted earlier, in Connecticut could be significant given how we use the provider tax in the state. Next slide. So as we think about the coverage impacts and what that means for care delivery in hospital systems, health systems, certainly the drop in Medicaid and marketplace coverage are concerning. Reduced access to preventive care and regular source of care for chronic conditions, which certainly could lead to more acute care required in a hospital emergency department. And as all of you know, I'm sure you've heard from your constituents, our emergency departments are quite full today. And to the extent more acute patients arrive at those emergency departments, that creates a systemic issue for us. As you know, we are required by federal law to treat anyone who comes into one of our emergency departments. And certainly we've talked about the increased uncompensated care costs as individuals without coverage seek that more acute care. One of the things that I think is something that we're paying attention to, hasn't been talked about today, but could have an additional impact, is the federal government appears to be changing the way FQHCs are able to provide care to individuals, to undocumented individuals. Since 1996, FQHCs have not had to ask their patients for their immigration status. The federal government appears to be about to change that requirement, which would require the FQHCs to understand immigration status before providing care. So to the extent there's a population of people in the state who currently are receiving their care from FQHCs who no longer would be able to receive that care there, their likely only other place to receive care is in hospital emergency department. And so it's something that we are paying attention to as that changes, but something that hasn't come up today that I just want to make sure you are all aware is something we're considering. Next slide. So I think what are the solutions to sort of, manage these changes? So certainly we have been approaching our community organizations and DSS about ways that we can help promote coverage in our hospital. Obviously, we have people who come into the hospital. We have the ability to get information from them to see if they're eligible for coverage. It's another opportunity to make sure that people who may be confused about their coverage eligibility, may have dropped coverage, but might be eligible. We can be an access point to try to keep people covered. So we want to talk to DSS about that process and how we can participate in those eligibility conversations. I think as DSS and OPM noted earlier, we want to see these provisions be implemented in ways that limit administrative burden. We don't want people to fall off of coverage because of a paperwork issue when they've otherwise met all of the requirements. And certainly appreciate that that's how the state's thinking about these provisions. We're advocating at the federal level for the extension of the enhanced premium tax credits. Glad to hear the presentation from DSS and from Access Health related to some of the other ways they're thinking about preserving coverage, and want to be part of those conversation. And then as we get into the financial ramifications of the HR1, we're going to be looking for a conversation with the state on how we proceed using the provider tax in a way that complies with federal law, but also significantly addresses the $1.4 billion Medicaid payment shortfall we're experiencing every year. So those are for us, the items that we're paying close attention to related to coverage, HR1, and sort of the future of healthcare delivery in the state going forward. So thank you very much. Happy to answer your questions.
Thank you very much. Besides some of the things that you mentioned in your slide in terms of lobbying for, continue some of these things, do you have any other policy recommendations for us while we either go into a special session or navigate the 2026 legislative session?
Yeah, so I think related to the provider tax, because it is so significantly large, an issue for the state budget and for payments in the Medicaid program. The settlement that we reached with the state expires at the end of this state fiscal year. And we will need a new provider tax program beginning July 1 of 2026, so the second year of the biennium. We need to understand now how the state is interested in using that program going forward. And we'll be looking for the legislature to help us navigate a new agreement related to that program. I think for this special session, one of the things we are considering is making sure that the state statute protects our provider tax program into the future. Prior to this legislative session, if CMS, the federal government, were to not approve certain aspects of our provider tax program, it would just revert back to what was approved. There is no language currently in state statute that gives us that protection. And so we want to talk with the legislature and the state about potentially re-implementing some language that would protect our program. We think it's in the best interest of the budget, but certainly the Medicaid program as well.
And then, we really don't want to see overburdened emergency departments. If something like that happens, or even now, does the hospital have like a navigator from Access Health or something in-house that can go, sign people up and enroll people now to kind of talk through insurance options? Because I feel like a lot of people are eligible for things that they just may not know. I mean, I know it's another thing to do, but how does that work now?
There's just interesting you noted. So today, no, but it's actually something that we want to start talking to Access Health CT about, is that, and we have some experience with Medicaid where we would have individual eligibility workers in the hospital assessing an individual patient, an uninsured patient, for Medicaid eligibility. And we think that you can use that same model, not just for Medicaid, but potentially for other sources of coverage as well. It's not something that we on the commercial side had thought about, but just recently have started to think about that as a model. So yes, I think that's something we want to explore.
Great. Let's definitely keep that discussion going. Any questions from the committee? Senator Cabrera.
Thank you, Representative. Thank you for being here today. Thank you for sharing your slides with us and giving us some insight. I'm curious, not knowing what exactly is going to happen, but kind of reading the situation the way it is right now after what happened last night in DC. There's a pretty good chance that the enhanced subsidies are going to be gone and not come back. That given that potential thing from happening, which I think was likely to happen, and then all the other changes. You referenced that your emergency rooms are already slammed. You're already doing. Can you give us some insight as to what hospitals are doing to prepare for an even larger number of people showing up at ERs? Number one, and number two, is there any work being done or any estimate as to what we're talking about here? How much more are we talking about here?
So it's interesting as you think about, I'll take the second part of your question first. So, and I think the Access CT numbers are helpful. So if you think about I think there was the 28,000 people over 400% of poverty who would just lose all of their subsidy. And then those individuals are making decisions. So did some of those individuals have access to employer coverage now that they would take up? That's a sort of question about whether they move to a different source of coverage. How many of those individuals were using healthcare services today? So did they have insurance and were using the insurance, or was it they had it and they might go to an urgent care every once in a while, but that was it. And so those are the things we're trying to calculate through is of those individuals who fall off of coverage, what is their current sort of need for services look like? And then it's hard to anticipate what are acute needs down the road for someone who has an accident or is diagnosed with an illness that they didn't know they had, those types of things. I think in the Medicaid population, which tends to be a sicker population and need more services, I think we have an idea that some of those individuals will be in our emergency departments more frequently than, say, otherwise. As far as how do we prepare for that in an emergency department context, it really is looking at hospital throughput generally. And where we have struggled is, if you think about, I come to the emergency department and I need to be an inpatient at the hospital, and then we need to look for a bed in our inpatient units to see, is there a bed that is suitable for you, for your condition? If there's not a bed, what's the reason why there's not a bed? Is there someone in that bed who could be discharged? And what's the reason they're not being discharged? Is it because there's no home health? Is it because there's no nursing home bed available? Is it because there's no safe place for the individual to be discharged? Is it because there's no outpatient services that the person needs? And so we're spending a lot of time on that part of the equation because it's harder to solve the emergency department issue, right? Space is limited and we expand space where we can, and we are attempting to ensure that when you come to the emergency department, that you're getting the care as quickly as you can. Our limiting factor are the inpatient units and discharging individuals who are ready to go home or to another level of care. And so we've been talking to our insurance colleagues about what are the processes we can use for individuals who have insurance to get authorized to move to the next level of care, to our nursing home colleagues around what are the barriers to getting people to the nursing home. So that's really where we're spending a whole lot of time on that, the how a patient moves through the hospital. And transparently, those are challenging obstacles.
I appreciate that. That's one of the things I think we're going to have to figure. We don't know, right? We don't really know until it actually starts happening. But I appreciate your answer to that. And that's we can talk offline if more, but I'd like to talk to you more about that because I think that is a problem that is quickly going to be brought to our attention. So thank you so much for sharing that.
Great. Thank you very much for your
Thank you
time
very
today,
much.
Paul.
Appreciate it.
We have Jeanette Thornton and
Jerry,
Susan
I had
Halpin.
a question.
Up. Sorry, your hand was not up.
It was, I just lowered it. It was up. That's okay.
Okay.
Thank
Please go
you.
ahead.
Thank you. I just had a kind of a question, kind of a brain blast that I had been thinking about. I've been talking to a few people. I know there's been a lot of talk about if and when people lose insurance and this deluge of people that are going to be at the emergency rooms. And I think there's some people that are out there saying, well, people have to go to the emergency room for care. And I was wondering, from the larger hospital networks, especially, maybe not the rural ones, but the larger ones, especially in the cities where we're going to see probably a higher population of people that might lose benefits. Has there been any thought from the hospital networks to incorporate, it's an older model that I know we had at Rockville Hospital, had to be probably about 20 years ago or so, but to have an adjacent urgent care center where you have somebody come in, get triaged. If they don't need emergent care, you can direct them over to the urgent care center. And even more importantly, if they are there for something that is routine, set them up, help them set up with a community care clinic where they can get routine care. So that way we're not seeing more people sitting in emergency rooms, kind of a direction to the correct level of care.
Yeah, Representative Nuccio, thanks for bringing that up. I think it's a really important point. And our health systems are doing that, and with education to patients around what is an emergency level of care, what could be treated at your urgent care center, what is better for your primary care physician's office. And certainly we do have those urgent care centers available. We are always aware of our federal EMTALA obligations and making sure that we are never discouraging an individual from accessing care at the emergency department if that's what they believe as a prudent layperson they require. And so I completely agree with you that patient education is really vital on where care can best be delivered. Always keeping in mind that we do have those federal EMTALA requirements.
So I'm thinking more like live in action, right? And not so much an education program, which I agree we should have that now. But if you had basically like triage at the emergency rooms where you are not discouraging people, if they want to wait for an emergency room visit, they can. But for what you're presenting with, an adequate level of care would be right over here where our urgent care center is. You could go over there and be seen in a shorter amount of time. And if it's something that is more routine, right? Say, I've got a headache and I don't know why, kind of a thing. Kind of help to not
Yep.
to not treat them, but to kind of help direct them to a community clinic where they could
Yeah.
get regular preventive care.
Yeah, I totally understand. Once they enter the emergency department, we do have an obligation to assess them, to make sure that their condition is and stabilize them, and so then can direct them to a better source of care once we fulfill that obligation. But we do have an obligation to see them once they enter the emergency department.
Oh, yeah. I would agree with that. And that's why I mentioned like a triage, right? If somebody comes in, I know whenever I've gone to the emergency room not recently, it hasn't been a little while, but, they take your blood pressure, they take these things, they make sure that you're fairly stable before they just say, okay, go sit and wait, right? So it definitely see them, but referring somebody over to an adjacent, like an urgent care that's right there with the hospital, is first of all, a lower level of care, a more affordable level of care, especially if you don't have insurance. You're not incurring a large emergency room bill when you could incur a significantly smaller urgent care bill. So I'm just trying to think like out of the box because, I've heard quite a few times about, this deluge of people that are going to be looking for primary care now at the emergency room, or regular care at the emergency room. And how can we kind of stave that off with on the point, here we are, education, we've looked at you, feel like, this level of care would be more appropriate and more affordable for you. So it's just something
No,
I think we should think about.
Totally understand and absolutely. And I think one of our major concerns for individuals who become uninsured is that they won't be seeking a regular source of care at the emergency department. They will just wait until they are so acute that they come to the emergency department. And so at that point, um, we have lost the opportunity
Right.
to, right? So I think that's our primary concern is that people, obviously, they wait when they wait too long and then their condition is very acute.
Yeah, I think that's the combination of the education long term. Like, how do we make sure people understand where community clinics are, where urgent care clinics are, what's the level of care? So I think that's your ongoing education you were talking about. I absolutely agree. And like I said, I'm just looking for ways to, when people present at the emergency room, if it is not a truly emergent situation, how do we get them faster service at the adequate level of care at a more reasonable rate? So just thought I'd put it out there into the universe and see if maybe we can talk about it.
Appreciate that. Happy to. Thank you.
Thank you.
Paul, thank you.
Okay, thank you.
Next up, we have Jeanette Thornton and Susan Halpin. And I know that there was a time constraint for Jeanette. Is she still on? Yeah, okay.
Okay. I wasn't expecting that. So,
if you want, we could give you some time. We could do some public comment and you can come back up, whatever works for you.
I think much of what I would say today has already been said. So, I want to thank the committee for convening this group because I think we all learned something new today. It's a very tumultuous time with a lot of uncertainty. And I think the carriers that are participating in the exchange are very actively engaged in the situation and preparing accordingly internally to whatever they are able to do in anticipation of the changes that are coming. One of the things I didn't hear talked about a lot today were the rates. And I may have missed it when I was out of the room, but the rates that were filed and approved by the department, and I know Christine Cappiello is behind me and can kick me if I get it wrong, do anticipate that the subsidies will not be continued. So if in fact there is a last minute um, reinstatement of the subsidies between now and the end of the year, there will be changes to the premiums and the rates that the carriers currently have filed and been approved for. So how that process plays out will have to be in very close coordination with the Department of Insurance around that process. The other thing I guess would say, in terms of the conversations that have happened earlier today, there's been a lot of conversation about the market here in Connecticut. And I think I want to thank the commissioner really for his candor in that conversation, and talking about, the under 1% profit margin that has been allowed on, rates filed. I think that not only, impacts perhaps some carriers' decisions to be here, and this is Susan wearing Susan Halpin hat and commenting, not necessarily with feedback from the carriers, but I'm sure it's discouraging to those that are contemplating participating in this market. And the benchmark is a concern, as is a lot of the regulatory compliance issues that go around it, the reporting. So, the dollar amount is the one thing, but the heavy reporting requirements that go along with that have caused some consternation among the carriers, to be fair and to be honest and transparent. So I think it is a combination of things, and we have good partners at the department, at the state, at OHS. We are trying to work through a number of those issues and concerns, but they are ongoing. And as this committee has also talked and taken action on, as are the assessments and, the heavy mandates that come forward, they may well improve the cost of care improve health outcomes long term. There's no question that they may do that, but that outcome may be further down the road than what it costs today. And I think if we're going to go in that direction, we have to be prepared to pay for it. And that's why we have supported over the years the mandate review bill. We've also supported, adding a fiscal note so that you are well informed when you vote on these proposals as to what the immediate impact might be to the market and to your constituents. The other side about just the market and negotiating with the hospitals, I completely appreciate the comments that Paul Kidwell made about the cost of or the underpayment of Medicaid and other government programs. That is something we hear regularly, is that there is a cost shift to the commercial market for those underpayments. And it is something that you and we are paying as a result of that to pay those. What can be done in such a concentrated market? There have been proposals in this committee and by the administration and others that cap the payment for out-of-network services. So the incentive thereby being to be in network with a carrier. Those are some things that, could go a long way, as do some of the other proposals that have been before your committee that we've been lucky enough to consider. So those are just a couple of running comments that I had based upon today's discussion. I'm happy to answer any questions that you have. Insurance likes predictability. That's how rates are set, trying to take all of the dynamics in place and calculate and forecast what an appropriate rate will be. That's very difficult in the situation that we all find ourselves in. It is an ever-changing dynamic and market. And we are here and ready and prepared to work with you as together as we all try to navigate these new waters. So thank you for the opportunity to speak.
Thank you very much. Any questions? I do have just kind of one comment to make. All of us up here are experiencing this real time, where we're getting emails from our colleagues saying something like, a doctor in my district reached out, or a dentist in my district reached out. And, the carrier is, negotiating reimbursement rates, whether they're aligning it with, other carriers' rates within the market or pushing back on increases. And then we're getting the emails saying you have to legislate something, in this way. And, it's hard to kind of say, well, we are trying to comply with this benchmark that we have in place. Nobody wants to hear that. No one wants us to go through the explanation, but we do see the bubble of the system kind of really butting heads right now, whether it's the underpayment of the government plans or the federal government plans, Medicare, Medicaid, state plans, having the commercial side pick that up, whether it's having everyone comply with a benchmark. So it's not easy, but we do want to continue to be open to the dialogue of putting solutions forward and reacting in a way that still provides the best quality care that we can. So thank you for your time. Any questions? Okay, we will open it up to public comment.
I had questions.
Can you raise your hand, please?
It is up. Look,
Or
it's
should I
up.
just call on you no matter what?
You just call me no matter.
Representative
You know I
Nugent.
always have questions. I have one question for you, Ms. Albin. In regard to what I had spoken to the commissioner about in the new law that was passed regarding the cost growth benchmark and the frequently thrown around affordability factor for rates. Can you get into a little bit of detail on what exactly it would take for the insurance companies themselves to be able to mitigate the cost of care from such an affordability factor? And if they were forced to increase rates no more, or be penalized if their rates are higher than the cost growth benchmark, what repercussions that would have, or what powers they would have to reduce the cost of care to meet something that's being imposed on them?
Thank you. And I think it's a very important question. I think one of the things that gets lost in the conversation sometimes is that the way rate setting works in Connecticut, as I think the commissioner alluded to, there's only two factors that carriers can rate upon, and that is age and geography. And then they community rate their whole population of individuals and or small groups in one. So they take those factors and they are pooling. So to the conversations about pooling, they are pooling their whole group and coming up with a rate. So affordability is an arbitrary figure. As the commissioner said, right now they're making sure rates aren't too high, too low, and aren't unfairly discriminatory. What is affordable to me versus what's affordable to my son as a newly graduated college graduate are two different things. So what affordable factor are we going to overlay? And if we overlay an affordability factor that reduces those rates that the commissioner approves, what kind of chilling effect is that gonna have on the market? You've already seen a number of carriers leave the market, and at what point do existing carriers, does the pendulum swing too far in terms of their ability to operate here? So I think it puts us in a very precarious situation. I think if you asked the previous speaker, I think the benchmark is 2.9%. 2.9%? No, 2.9%. I think if you asked any hospital in the state if 2.9% was enough of an increase, or any provider group that's calling you as constituents, if 2.9% is enough for what they believe they need to continue operating, I think you would get the answer no. So that puts it puts carriers in a very, very precarious situation about how to continue within that regulatory framework. So the question is a good one, and we certainly look forward to working with this committee and with the administration and other policymakers to assure that the playing field is something that the carriers can participate in accordingly.
Okay, so I'd like to expand a little bit on what you just said. So if the cost growth benchmark is 2.9% and the hospital networks, the representatives from the hospital networks are saying, no way, right? There's no way we can guarantee no more than a 2.9% increase. And say their increase is 6 or 7%, right? And then based on the law that we just passed, the insurance company is held liable to not, like, their rate increase is significantly higher than the 2.9%. It's the 7%, right? And the insurance company is being penalized for that in this case. Do they have any power? Is there any way that what is their recourse as they're penalized for being over the cost growth benchmark for something that they don't really control? So what's their recourse? Is the recourse to just leave the market?
That is certainly, I think, the last resort for many carriers, but certainly one recourse that is a reality. I would also say, that they're looking to, control those costs. Obviously, folks would advocate for a change in that policy if that's where they find themselves. And, or I think most, really importantly, and you've heard me testify to this during the legislative session, the ultimate consumer protection for a carrier is to pay a claim for a medical service incurred. If a health plan is not getting adequate funding, they are not able to pay those claims. And you've seen in the past with organizations that formed to provide insurance, they became insolvent and could not pay claims. So there are dangers to not having sufficient rates, and I think an affordability factor could play into that in an unintended way. So we would express very, very, very strong caution in moving in that direction, and even in fact, in what's already in place.
Perfect. Thank you very much. I appreciate your answers.
Great. Thank you very much for being here, Susan. We'll open up to public comments. We have 2 people signed up, but anyone in the audience is welcome to come up after them. We have Grace Brangwin from CBIA.
I came prepared, obviously. All right. Good afternoon to the chairs, ranking members, and members of the Insurance Committee. My name is Grace Brangwin, and I'm a Public Policy Associate for the Connecticut Business Industry Association, covering insurance, among many other topics. Today, I will be speaking on some of the trends in the small group market from the employer side and some solutions to address the coverage gap for this demographic. Last month, CBIA released our annual survey of Connecticut businesses, which pinpoints some of the challenges our members face when growing their company in the state. The number one issue that respondents believe the General Assembly should be addressing in the 2026 session is healthcare costs and affordability. Since 2009, the share of small businesses in Connecticut that offer health insurance dropped by nearly 25%, and the landscape of options for businesses with 2 to 10 employees is truly desolate. And with the departure of major carriers from the small group market, employers face the difficult decision to reduce or withdraw benefits entirely. Employers need different options that provide high quality, affordable health care to their employees. And for the past few years, CBIA has lobbied in strong support of association health plans, a form of employer-sponsored healthcare that allows small businesses to pool their risk and receive benefits through their trade association. And because underwriting occurs at the group level as opposed to the individual level, risk is spread out among all the members of the trade association. And I would also like to emphasize that our version of association health plans covers all essential health benefits as well as state health benefit mandates pursuant to Connecticut General Statute 700C. And our version also covers the equivalent of ACA bronze, silver, and gold plans. Finally, I really want to drive home that CBIA's version of association health plans strictly prohibits any form of discrimination based on pre-existing conditions. And as someone who has participated in prior coalitions in support of association health plans, I can vouch that this policy has received not only bipartisan support, but the support of diverse industries across the state, thus demonstrating a widespread need for more options. In addition to association health plans, CBIA also formed its own level funded plan, known as Health Connections. And businesses who level fund pay a monthly premium equivalent based on the number of expected claims and stop loss policy costs associated with this health plan. Our level funded plan marries the cost predictability of a fully insured plan and the cost savings of a self-insured plan. Health Connections also provides enrollees a surplus refund if the number of claims incurred is lower than expected, thus putting money back in our members' pockets. Ultimately, healthcare solutions for small businesses are not red issues or blue issues. They are affordability issues, and CBIA is committed to advocating for more options in the shrinking small group market. Thank you again for the opportunity to speak on this topic, and I open myself up to any questions.
Thank you, Grace. I was wondering, after you heard everything going on today, I was, surprised and encouraged to hear OPM talk about, these types of plans as something we need to look at. Were there any other things either presented today or presented through our committee in the past that we should be talking about in the upcoming 2026 legislative session?
Yeah, absolutely. So some things in the past that CBI has lobbied on, as Susan talked about, are health benefit mandate reviews, as well as the fiscal note that would tell policymakers and also potential enrollees the impact of any new mandate that the legislator would pass. So I think, increasing transparency is a huge priority for employers and also employees as well. At the end of the day, businesses have to do right by their employees. And part of that is, comfort in knowing that their company has their back. So at the end of the day, the more transparency, the better.
And CBIA formed your own plan that you had referenced. Is that utilizing a captive insurance?
Yeah, so there's been a few questions about this. So the product itself is not a captive. CBIA formed its own captive to kind of subsidize and take on any potential risk that the actual product itself offers. So the level funded plan, again, is not a captive, but we do think that it is an option for many of our member businesses.
And how many of your member businesses or how many individuals do you have in that plan?
That's a great question. I'll have to get back to you on that, but I can certainly follow up with the committee after conferring with our insurance department.
Thank you. Any other questions? Thank you, Grace. Next, we have Paul Vance.
Good afternoon. Thank you for giving me a few moments. I know you've had a long day, but I'd like to offer some brief comments to the honorable members of this committee. My name is Paul Vance. I'm the president-elect of the Connecticut Bar Association. The CBA represents more than 8,000 lawyers across the state, and together with their firms, many thousands of people when you include employees and family members. I can testify that our members, nearly half of whom are solo and small firms, struggle to provide their employees with affordable or acceptable health insurance coverage. I myself am the owner of a small business, a law firm that employs 5 people, and the high cost of health insurance makes it an impediment to compete in the market. I ask that legislation be considered to authorize these association health plans. They'll help our members who will benefit from an opportunity to pool their insurance needs. It will be a game changer for thousands of people across Connecticut who work in legal services. I thank you all for your kind consideration. I know you've had a long day, but I'm happy to answer any questions. Otherwise, I look forward to seeing you all outside of this hearing.
Thank you, Paul. And are your members currently that are solo practitioners, are they on the Affordable Care Act or are they using some other form of insurance?
It's all over the place, Representative Wood. It ranges from people relying on spouses who have access to health insurance. I have people in my firm who have chosen not to make a purchase because of their age, and so they pay out of pocket. So it really depends on the firm. I know my predecessor as the president, Tim Sharon, he works at a large law firm with more than 150 employees, and it's a challenge for them. I represent a lot of solo and small firms, and some are in the exchange, some are on Husky, some just go without health insurance or rely on either family members or spouse that can provide coverage.
Thank you. We appreciate you waiting through the hearing today to come speak publicly. Any other questions?
I learned a lot today from
you.
listening. So,
Do we have anyone else that wants to speak in the room or online? Great. Thank you, everyone, for your time. Have a wonderful rest of the day.